So, hello everyone. I'm Dr. Omkar Sangita Dilipra from Team Afmge, and today I'm back with another session of FMG June 2022 session recall. So here today we'll be discussing some more questions of FMG June 2022. It would be random, but I'll be more focusing on the major subjects: PSM, medicine, and surgery, because most of you are usually confused with these recalls. So without any further delay, let's start. And I'm glad and happy that these questions, also most of them, were from the AFMG notes, as well as from the chanting, test and discussion sessions, as well as the QRS session. So I'm glad that most of you have been able to answer those. And all those aspiring for December 2022, almost we have started our sessions. So if you wish to join AFMG, please do contact as soon as possible. Okay, so we are soon starting our batches from 15th of June, and subsequent batches would also be started. Thank you so much for that. Let's move on to our discussion now. Starting with the first question, according to WHO, the maternal mortality is defined as, according to WHO, maternal mortality is defined as. So we have discussed much about MMR, that is maternal mortality ratio, right? And as I told you, what do we mean by MMR? It is number of maternal deaths upon the total number of live births into 1 lakh, and it is a ratio, right? This we have discussed. According to that, along with that, I have also mentioned in OBG as well as in PSM that the definition of maternal deaths is any death during pregnancy, any death during labor, and any maternal death during 6 weeks after delivery, right? Why 6 weeks after delivery? Because we have discussed that usually 42 days after delivery or 6 days after delivery, this period is considered as purpurium. This period is considered as purpurium, and therefore there is a high chance of maternal mortality during this period. It can be due to some delivery complications. It can be something like postpartum hemorrhage, usually a secondary PPH, okay? Or there can be some other causes also which can lead to death of the mother, usually in this purpureal period, right? So the best answer here would have been maternal mortality is defined as maternal deaths antenatal, that means during pregnancy, till 6 weeks after delivery. Okay, this is the best definition for maternal mortality. And why 6 weeks? As I told you, the first 6 weeks after delivery or the 42 days is usually considered as the purpureal period. And there the mother is at a higher risk of death due to all the delivery as well as pregnancy complications, right? No issues with this, anybody? We have discussed this in our classes. Moving further to question number 62. I have discussed about breast and cow milk differences. Over there, I have mentioned about this. Even ma'am would have also mentioned in our classes, Dr. Neha ma'am. So I don't think so there would have been problem answering this question as well. Which among the following vitamin is deficient in breast milk? Right? Which among the following vitamin is deficient in breast milk? So if I talk about the human milk as well as cow milk, guys, okay, important things, important differences if I need to mention. First of all, as I told you, usually lactose or carbohydrates are more in human milk. Lactose or carbohydrates are more in human milk, okay, important. Whereas proteins are more in cow milk. Proteins are more in cow milk. As we know, usually whey protein is present in human milk, whereas casein protein is present in cow milk. C for C, as I've already told you, okay. Iron is present in high amounts usually in human milk or breast milk. Apart from that, calcium is to phosphorus ratio is high in human milk, and therefore calcium absorption is better in human milk, but calcium and phosphorus content is high in cow milk. Okay, calcium and phosphorus content is high in cow milk. Apart from that, if we talk about the vitamins now, right? As we know, in cow milk, vitamin C is deficient. In cow milk, the most deficient vitamin is vitamin C. But in human milk, the vitamins which are deficient is usually vitamin D and vitamin K. Okay, the vitamins which are deficient in human milk are vitamin D and vitamin K. But at least vitamin K we have in some amount, but vitamin D is the most deficient vitamin in human milk or breast milk. So here the answer would have been option A. Vitamin D is the most deficient vitamin in human milk or breast milk, right? And therefore usually we give vitamin D usually 400 international unit. As we have discussed, as I told you, usually till the first year of life, okay, in the first year of life and during infancy, the child is given vitamin D 400 international units, right? Apart from that, as vitamin K is also deficient, as I told you, it is given at birth. Vitamin K injection is given at birth to prevent hemorrhagic disease of newborn. This was a PYQ as I discussed. And it is given 0.5 mg in a preterm neonate, whereas 1 mg injection is given in a term neonate, right? All of this I have discussed. So vitamin D is the most deficient one, but in India, the chances are lesser because in India we expose our neonates to the sunlight, and therefore vitamin D synthesis occurs usually in the skin, then liver, and finally in the kidneys, right? So in India, the incidence of vitamin D deficiency in neonates is lesser, but worldwide it is much more, okay, usually in cold countries. Moving further, guys, question number 63. Counseling and screening is done for tuberculosis in a HIV positive patient at ICTC, that is Integrated Counseling and Testing Center. ये image और logo भी बताया था मैंने. At ICTC Center under the National AIDS Control Program. This is which level of prevention? We have discussed all levels of prevention, okay? So first of all, we have the primordial level of prevention, which is before the emergence of risk factors, before the risk factor appears. Then after risk factor appears, but before the disease, we have primary level of prevention. After the disease starts, usually, we have secondary level of prevention. And once the disease is over completely, okay, during that phase, we apply the tertiary level of prevention, right? As I discussed already, all the table, primordial level of prevention is usually health education. Primary level of prevention is health promotion as well as specific protection. Secondary, it is early diagnosis of a disease. That means a screening test or a diagnostic test for a disease, as well as treatment for the disease would come in secondary level of prevention. As well as once the disease is over, the person is having some disability. Therefore, tertiary level of prevention would be disability limitation as well as rehabilitation, right? So all of these things have been discussed in our PSM sessions multiple times. I don't think so you would have any issue with this. So now they gave two things important. First is counseling. Counseling is usually done before the disease starts, okay? If the risk factor is present, like over here, the patient was HIV positive. That means it was a risk factor for most of the opportunistic infections. And as we have discussed, the most common opportunistic infection in a HIV positive patient in India, it is tuberculosis, whereas worldwide it is Pneumocystis jirovecii pneumonia. So as the patient is having a risk factor, that means he is immunocompromised due to HIV positive status. Therefore, he is at a high risk of developing opportunistic infections, and the most common one being tuberculosis. Therefore, a counseling is usually done. So risk factor is present, but the disease, that is TB, hasn't started in the patient, right? And therefore, counseling is done. So counseling before the disease starts, but after the risk factor, then this is usually primary level of prevention. But here they have also given screening. And as I told you, screening tests, diagnostic tests, any of the treatment options, all of them are usually for early diagnosis of the disease, screening test and diagnostic test. And therefore, it is secondary level of prevention. So if both of these things were given in the question, it was better to mark option C, primary as well as secondary level of prevention. Counseling comes under primary, whereas screening comes under secondary level of prevention. I don't think so there would have been any issue with this. Okay? So as I always told you, TB and HIV are the most important topics from PS as well as from other subjects as well. Moving further, guys. Now talking about this question, it says, which of the following is not a health worker at village level? Okay, not a health worker posted at village level. We have discussed about the health system in India. All the health workers in India who are posted at various levels, their qualifications, everything was discussed by Neha ma'am, by me multiple times. Okay? So इसमें कोई दिक्कत नहीं आई होगी, I hope so. As we have discussed, ये तो तुमने table मुझे, most of you send me the screenshot of our QRS notes itself. So this came करके. So option B says ASHA worker. As we know, ASHA is accredited social health activist, and ASHA worker, as we know, she is posted at the village level, right? She is elected by the Gram Panchayat, accountable to the Gram Panchayat, right? She is a member of the same. She is member of the village health and sanitation committee. She is a resident of the same village, okay? A female between 25 to 45 years of age group. All of that we have discussed. That means ASHA worker is located at village level. Traditional birth attendant, that we call as DAI in the common language or layman language. So this traditional birth attendant is usually also located at the village level for home delivery purposes, right? If any of the trained healthcare worker is not available over there, right? So, or to assist the A&M or multi-purpose worker female, right? So she is also located at village level. There was a confusion between Anganwadi worker and auxiliary nurse midwife. As I have always discussed, सबको MPW female तो जरूर याद था, multi-purpose worker female is located at sub-center level. But as I always told you, if multi-purpose worker female is not available, the other healthcare worker who is posted at the sub-center level is A&M, auxiliary nurse midwife. Okay, almost they are the equivalent positions, auxiliary nurse midwife or the multi-purpose worker female. Right? ये मैंने बात की थी, and they are responsible for delivery usually at the sub-center level. Okay, whereas Anganwadi worker, as we know, Anganwadi worker is located at the Anganwadi center. Okay, And Anganwadi center is usually located in urban areas as well as villages also. So one village would have minimum one Anganwadi center, right? So Anganwadi Sevika or Anganwadi worker is also located at the village level. Sub center bhi village level pe hota hai. Okay, sub center is also located at the village level. But what is the population norm for sub center? One sub center per 5,000 population in plains and one sub center per 3,000 population in hilly or tribal areas. That means usually a sub-center is not for a particular village, rather it is for minimum 3 to 4 villages, right? One sub-center, depending on the population, it is minimum for 3 to 4 villages usually, or maybe 2 villages if the population is higher, right? So here, agar hame rule of exclusion se answer nikalna hai, so the best answer here would have been option A, ANM, auxiliary nurse midwife, is not actually located at the village level. She is located at the sub-center level, and sub-center is a combination of 2 to 3 villages minimum. ठीक है, कोई दिक्कत नहीं है. So I hope all of you have marked it right. Moving further, this was a straight away definition. Role of social factors in disease causation is studied under. So I hope this was easy. Role of social factors in disease causation. Any of the social factors, that can be something like a person belonging to a low socioeconomic status, okay, where there is a high incidence of substance abuse, alcoholism, drug intake, maybe prostitution in usually a red light area. Okay, so all of these are social factors. Apart from this, definitely there are multiple other social factors, maybe superstitions in that particular community. So all of these would contribute to the disease causation, some of the other diseases in that particular community and or the particular society. And this is what is known as option D, social pathology. Okay, so role of the social factors causing a disease is actually studied under social pathology. It is studied under social pathology. No issues with that, anybody? I hope so. This was easier for all of you. A straight away definition, nothing to be discussed more about that. Okay. So one or two agar nahi bhi aaya hai question, as I always showed you, one or two questions would be out of the box, and that's absolutely fine. Okay, na? PSM में, if usually there were 35 questions, it is not like easy to just mark all the 35 questions right. Your target should be at least 28 to 30 questions you should mark right. Okay, and I hope most of you have marked it right. Question number 66 now. Patients from different age groups from just a minute. Patients from different age groups from a village in West Bengal came to the clinic with same illness. On examination, it is noted that all of them were having edema. So all of them were suffering from edema. On history taking, it was found that they were consuming mustard seeds bought from the same local shop. So this is important. Okay, so all of them were having the same illness or same disease with the same complaint of edema, right? And all of them were consuming the mustard seeds which were bought from the same local shop, which is the most probable diagnosis. So definitely, if they are giving you some diet history, as I've always told you, last time they asked that there was a case of Laparoscopic and what history you will take. So you will take the diet intake history, right? Ye question the last time PYQ mein. This time they just twisted the question. They gave you the diet intake history, and if they are giving you any history for diet intake, definitely they are thinking in terms of adulteration diseases. They are talking in terms of adulteration or any food related diseases. So here they are talking about adulteration disease where the patient is having some symptoms on consumption of mustard seeds. As I've always discussed, that in mustard oil, usually in mustard oil, the adulterant which is mixed, that adulterant is actually called as Argemon mexicana oil. Okay, that adulterant is called as Argemon oil or Argemon mexicana oil, and this Argemon oil usually contains a toxin known as sanguinarine. This Argemon contains a toxin known as sanguinarine, and as we know, if the people consumes this mustard seeds or mustard oil which is adulterated with Argemon oil, and this Argemon oil will release the toxin known as sanguinarine, this will lead to cause a peripheral edema in the patient. Along with that, the patient can also develop congestive heart failure. Along with that, as I told you, due to excess production of aqueous humor, the patient can even develop glaucoma, and finally that can even lead to death. All of these factors combined. Okay, so here definitely the answer is nothing else but option C, epidemic dropsy. Sanguinarine causes epidemic dropsy in the patient. Okay, edema, CHF, and glaucoma usually in the patient, and it is due to mixture of Argemon oil or Argemon seeds usually in the mustard or mustard seeds respectively. No issues with this, anybody? I hope this was easier. Lathyrism we discussed, it is due to a toxin known as BOA, right? That is beta oxalyl amino alanine, and it is due to mixture of the kesari dal, which is the adulterant, into the normal arhar dal, right? That is the cause. Endemic ascites, it is due to pyrrolizidin intake. As we know, it is the toxin pyrrolizidin. whereas aflatoxicosis, a very straightforward one. Aflatoxicosis can be easily ruled out because it is due to intake of aflatoxins, which are usually present in groundnuts, right? So worker usually in the groundnut factory would develop aflatoxicosis, finally leading to HCC, hepatocellular carcinoma. All of this have been discussed in a table format, so koi dikkat nahi aayi hogi. Next, moving further, the question says 67, if arhar dal is found to be contaminated with kesari dal, as I told you, normally arhar dal is adulterated or contaminated with mixture of kesari dal. Which of the following will not be done? So if arhar dal is contaminated with kesari dal, this kesari dal contains a toxin known as BOA, that is beta oxyl aminoalanine, and that can land up the patient in adulteration disorder known as lathyrism usually. Okay, it can be osteolathyrism in animals and neurolathyrism in humans usually. So the patient can develop lathyrism. So which among the following will not be done for this? So the stepwise approach would be, first, ban the crop usually. Okay, so ban the crop of this kesari dal, that would be helpful. Second, remove the toxin. Okay, remove the toxin. Toxins can be removed by multiple methods like tipping vagera. So remove the toxin by multiple methods. Then option D says vitamin C prophylaxis. Yes, vitamin C prophylaxis have been proven useful in prevention or prophylaxis of lathyrism. So that can also be done. Okay, these can be done. Okay, so these can be done. Whereas option C says give DEC, that is diethyl carbamazine. And as I told you, diethyl carbamazine is a drug which is used for filariasis, lymphatic or Brugian filariasis. For these conditions, we use DEC. Okay, DEC prophylaxis or DEC as a treatment is given in cases of filariasis and not in cases of adulteration diseases. So this can be easily removed. No issues with this, anybody? So I hope this was easier one again. Next, question number 68 says, in a country, low births and high deaths were reported. Which stage of demographic cycle will be present? So I hope this was an easier one, because we have discussed about the demographic cycle and all the 5 stages of demographic cycle. Yes, there are 5 stages of demographic cycle. The first one being the high stationary stage. Okay, and in high stationary, as we know, there would be high birth rate as well as a high death rate in the country. Okay, so this is what the high stationary stage is. Second one, as we know, it is the early expanding stage. Stage 2 is the early expanding stage. Here, as we know, usually due to healthcare facilities, the death rate starts to decline, but the birth rate is still higher. And therefore, the demographic gap or the growth rate usually it starts to widen, right? Third is usually the late expanding stage. Late expanding, India is currently in this late expanding stage of demographic cycle. Here, what happens due to the healthcare facilities, death rate is declining, but now birth rate also starts declining due to the national family planning programs, right? But death rate is still higher as compared to the birth rate decline. Okay? Then fourth one is usually the low stationary stage, and low stationary stage, as we discussed, usually here now birth rate is also declining and death rate is also declining almost at the same rate, right? Therefore, the population remains constant or stationary. And last, fifth is the declining stage. Yahan pe ulta hoga now. Okay, last is the declining stage. Here, what happens? Death rate is higher. Okay, death rate is declining. Death rate is usually higher. Please remember, whereas birth rate is also higher. But please remember, birth rate is usually lesser as compared to the death rate. Iska matlab death zyada ho rahi hai as compared to the births usually. Okay, that is important. Okay, that is important. Death zyada ho rahi hai as compared to the births in this population. And here also in the question they have mentioned the same thing. There are low births and high deaths. Okay, agar birth kam ho rahi hai aur death zyada ho rahi hai, that means the population is declining. So answer would have been easy. That is stage 5, option D. Declining stage was the answer. If there are low birth rate and a high death rate, that is suggestive of a declining stage of the demographic cycle. As I've already discussed about the growth rate or demographic gap, it is difference between the crude birth rate and crude death rate. Minimum demographic gap, as we know, it is seen in stage 1 and stage 4 because both of these are stationary stages. Maximum demographic gap is usually seen in late stage 2. Okay. Whereas inverse or negative demographic gap is seen in declining stage, that is stage 5. Ye sab kuch discuss kar chuke the. Moving further, guys, now question number 69 says blood bag should be deposited in which category bag? This we know, biomedical waste we have done in great details. So most of you are having issues. Okay, so yaad rakhna, as I've always told you, plastics and rubber usually are discarded in red bag. Plastics or rubber are usually discarded in red bags, but that plastic which releases PVC on burning, right? So syringes ho gaye, baki plastic, gloves ka rubber ho gaya, syringes ho gaye, all those plastic that will release, and that rubber will release polyvinyl chloride. okay, when it goes to incineration, and that can cause angiosarcoma of liver in the workers over there. Okay, so easily we try to avoid gloves, though they are stained or unstained, and plastics over there. But blood bag is also made up of a special type of plastic, but that is a medical plastic which does not release much of PVC, and therefore blood bag can go into option A, yellow bag. And why it goes into yellow bag? Because blood actually comes into the microbiological waste. It comes into the biotechnological and microbiological waste. Therefore, it goes into the yellow bag. And the main problem kya tha hame? Why we were not sending it into the yellow bag? Because PVC release hota hai. But usually the blood bag is designed in some such manner. It is made up of such a plastic that it will not contain much of PVC. Okay? No issues with this. So important. Moving further, guys, now question number 70. Relative risk is calculated in which study? So we know relative risk is usually calculated for measuring the strength of association, where the risk factor is associated with the disease or not. Okay, to assess this, whether the risk factor is associated with the disease or not, we calculate the strength of association by relative risk. And relative risk is usually calculated in option A, cohort study. This was a pretty straightforward question. What is the formula for relative risk? It is incidence in exposed upon incidence in non-exposed. Okay, it is incidence in exposed upon incidence in non-exposed. And I hope this was easier, because I told you wherever there is incidence is only calculated in one type of analytical study design, and that is cohort study. Okay, anywhere else we cannot calculate incidence. Because why? Because incidence is nothing but total number of new cases, and new cases tabhi calculate kar payenge when you are following the patient from risk factor to disease. Right? So it is usually seen in a forward-looking study or a longitudinal study like cohort study. Okay, na? So incidence is only calculated in a forward-looking study, and that is cohort. Okay? So incidence or relative risk are calculated in cohort study. If relative risk value is more than 1, as I told you, I discussed the NEET PG question this time. If it is more than 1, then there is a positive association. That means risk factor is associated with the disease. If it is equal to 1, there is no association between the risk factor and disease. And if it is less than 1, that means the risk factor is not associated with the disease, rather it is protective in nature. Question number 71 now. A patient presents with blue lines on gums. ये तो हमने discuss कर लिया था. Okay, along with abdominal cramps and constipation. Some people are saying, they even mentioned a painter or a paint factory worker. So if they had mentioned paint factory worker, then it was a pretty straightforward question, because as we know, usually painters or paint factory workers, okay, the occupational disease that we encounter usually is lead poisoning. Okay, it is usually lead poisoning or plumbum poisoning, that is known as plumbism, right? And lead poisoning, I have discussed it in great details because it was a recent question in NEET PG this year. So lead poisoning or plumbism usually is seen in painters or paint factory workers, and they will present to you with blue line on the gums, and these blue line on gums in lead poisoning are called as Burtonian lines. These are called as Burtonian lines, along with abdominal cramp or colicky pain, and therefore it is called as painter's colic. Okay, that also we discussed. So along with abdominal cramps or colicky pain and constipation. So I told you all other will lead to diarrhea except lead, which will lead to constipation, right? So the patient will have all of these features. The diagnosis is definitely lead poisoning. So they are asking you what will be the next line of treatment in this patient. So you have diagnosed it as lead poisoning. So now what is the next line of treatment? So they have not given me a clear idea whether there were combination options also. Some people are saying there was EDTA plus dimer cap, or there was only EDTA, there was only BAL. So no issues. I have always discussed, okay, we can give two things in cases of lead poisoning, okay? That is EDTA and BAL. BAL is British anti-revicide. And I also give BAL usually, iska jo mnemonic hai, it is B goes for bismuth, A goes for arsenic, and L goes for lead. Okay, so BAL is usually given in these three poisonings, whereas EDTA, as we have discussed, that it is usually given in cases of lead poisoning. So please remember, usually in the initial stages, only we give EDTA as the choice. If you need to choose among both of them, EDTA is the first line antidote or a chelating agent which is given in cases of lead poisoning, as we discussed. Okay, then second line would be BAL. Okay, usually in higher doses of lead, then we can give BAL. But the first line is EDTA, and if the option was EDTA plus dimercaprol, definitely that would have been the best answer. No issues with this, anybody? Moving further, guys, now. Question number 72. Which vitamin deficiency is the cause of the following condition? This image, most of the people are saying this was the ditto image which came in the examination, and this was the image you can find in our biochemistry, PSM, almost every other chanting that I have taken, right? In the QRS session also, I have discussed about this. So this is the classical image. Here you can see the patient is suffering from some dermatitis, and this dermatitis is usually around the neck predominantly, and this is what is known as our Cazals necklace, right? This is known as your Cazals necklace, and as we know, dermatitis around the neck or Cazals necklace is a feature of pellagra. It is a feature of pellagra, and as we know, pellagra is due to vitamin B3, that is niacin deficiency. So here, the vitamin deficiency leading to this condition, that is pellagra, is nothing else but option A, niacin. This was a pretty straightforward one, and as we have discussed, usually pellagra is remembered by 6 Ds, right? So first D is usually diarrhea, second D is usually dermatitis, that is your Cazals necklace, third D is usually dementia, fourth D is usually depression, fifth D is delirium, and sixth D is death. Okay? So all these 6 Ds, as I've always told you. We have discussed all about all the other vitamin deficiencies also in a single table, so it was easier for you. Thiamine, as we know, thiamine is vitamin B1, and deficiency in normal individuals will lead to beriberi, wet or dry beriberi, whereas in chronic alcoholics it will lead to Wernicke-Korsakoff syndrome. There was some question on Wernicke-Korsakoff. Please let me know. I haven't got the proper recall for that one. Okay, vitamin B9, that is folate or folic acid deficiency, will lead to megaloblastic anemia and neural tube defects, that we have already discussed. Whereas riboflavin, that is vitamin B2, we discussed. There would be a classical triad. Here the patient will suffer from angular stomatitis, which is the most pathognomic feature, chelosis, and glossitis, that will lead to a geographic tongue. Okay. Moving further, question number 73, which is the causative organism for cat scratch disease? This was a question I discussed. Definitely Dr. Vikas would have discussed in his sessions. I have discussed in chanting sessions as well. So the causative organism for cat scratch disease, we know it is option B, Bartonella henselae. It is Bartonella henselae. Okay. Bartonella quintana, as I told you, most of you were not sure. Bartonella quintana is a causative agent for trench fever. Yaad rakhna. Bartonella quintana is a causative agent for trench fever, whereas Bartonella henselae is a causative agent for cat scratch disease. I even discuss about the granuloma which is seen. Stellate or star-shaped granuloma is a feature of cat scratch disease. No issues with this, anybody? Okay, so please remember this. Moving further, question number 74 now. A child presents with normal height, but weight is lesser than the expected for that particular height. He is classified under. So I hope so this was easier. Height is normal, but weight is lesser than expected for that particular height. That means weight for height is lesser. Okay, and weight for height is lesser, it is suggestive of acute malnutrition. Weight for height is lesser, that is suggestive of acute malnutrition. And this is nothing else but this I have discussed in PSM, in pediatrics, both of them. Teachers, faculties have also discussed in their classes. So low weight for height is suggestive of acute malnutrition, and is nothing but option B, wasting. It is nothing but option B, wasting. Whereas if height for age is low, it is suggestive of chronic malnutrition. Height for age is low, it is suggestive of chronic malnutrition, and it is suggestive of stunting in the patient. Whereas if weight for age is low, it is suggestive of acute on chronic malnutrition. It is suggestive of acute on chronic malnutrition. No issues with that. Please remember this. And usually it is suggestive of underweight child. Weight for age agar low hota hai, then it is underweight. Weight for height agar low hota hai, it is wasting. And if height for age agar low hota hai, that is what is stunting. Okay, no issues with this. Kwashiorkor can be easily ruled out with the protein energy malnutrition. Moving further, guys, now. Question number 75. All are present at community health center, CHC, except, as we know, CHC or community health center is usually the secondary level of health care system in India, and all of these are present usually at a community health center except option A says surgeon. Yes, specialists are usually present at a community health center. We discussed that at least 1 or 2 Ayush medical officers, minimum 2 MBBS medical officers. Apart from that, definitely an ophthalmologist, a surgeon, an anesthetist, okay, an anesthetist, a pediatrician, okay, MD medicine guy. All of these are usually present at a CHC level. Apart from that, definitely a blood bank is available. Because at CHC you need some, you do deliveries, you do all of that, you do surgeries as well because surgeon is available, right? So all of these are there. Definitely a blood bank is required at level of CHCs. Usually at some CHCs it is definitely not present, but at some of the CHCs blood bank is also present. Please remember, intensive neonatal care, agar ye option tha, then this definitely is usually present at the tertiary level of healthcare. Okay, intensive neonatal care is present at the tertiary level of healthcare. No issues with this, anybody? So please remember that would have been an exception. Moving further, question number 76 says how to compare life expectancy of 2 different countries. So if we need to compare life expectancy, we need to measure the disability adjusted life years of these two countries, okay? Or the disease burden in the particular country. And disease burden, indicator of disease burden in a particular country is measured by option B, DALY. DALY is disability adjusted life years. And as we have discussed, DALY or disability adjusted life years is an indicator of disease burden in a society or a country. It is an indicator of disease burden in a society or a country. Okay. And depending on that, you will measure the life expectancy. Okay? Life expectancy is also measured by Sullivan's index, but that was not an option. Okay? So here, life expectancy of two different countries is measured by DALY, disability adjusted life years. QALY is quality adjusted life years. Okay, so that is not indicator of life expectancy. HPI is human poverty index. If you need to measure or compare poverty of two different countries, then you can definitely consider HPI, human poverty index, or MDPI, that is multidimensional poverty index. Whereas HDI, most of you are confused, human development index. I always told you human development index is an indicator of socio-economic status of a country. It is the indicator of socio-economic status and health status of a country. Okay? It is not a measure of life expectancy. Here, we will also consider income. Therefore, it is more likely a measure of socio-economic status or health status of a country. Okay, now? Moving further, question number 77 now. A patient complains of palpitations. Okay? On examination, irregular radial pulse is present. And as I told you, अगर ये question में दिया गया है, irregular pulse, you don't need to think in terms of anything else apart from atrial fibrillation, right? So a patient complains of palpitations. On examination, there is an irregular radial pulse, and ECG shows absent P wave. And as we have discussed ECG in great details in the integrated sessions, definitely Manish sir would have also discussed that. Yaad rakhna, P wave is suggestive of atrial depolarization. QRS complex is suggestive of ventricular depolarization, and T wave is suggestive of ventricular repolarization. So if P wave is absent, that means the atrial contraction or atrial depolarization is not occurring. Agar atrial depolarization or contraction is not occurring, that means the pathology is located somewhere at the level of atria. ठीक है ना? And QRS complexes के बारे में कोई mention नहीं है. That means the QRS complexes might be normal in this patient. ठीक है? But important thing is there are absent P waves. अगर absent P waves, that means the pathology is at the level of atria. So either it can be atrial fibrillation or paroxysmal supraventricular tachycardia. Right? You can easily rule out VT and VF, that is ventricular tachycardia and ventricular fibrillation. Right? With this important, they have given irregular radial pulse. So in PSVT, usually there is tachycardia in the patient, but the pulse is regular. In atrial fibrillation, as we have discussed, usually the distance between the RR interval is less or more. Okay, so the distance between RR interval is irregular, and that usually gives a irregular rhythm and irregular pulse. So here the diagnosis was straight away atrial fibrillation. No issues with this, anybody? And in NEET PG also, I told you about this. Atrial fibrillation is an important topic. In NEET PG, I told you, they asked you about the GVP. Okay, there was a cannon or a giant A wave. Next, moving further to question number 78, a patient of chronic stable angina is having peripheral edema, hepatomegaly, and raised JVP. Now, some people are saying there were features of right-sided heart failure. Some people are saying there were only it was only written that the patient is having signs of heart failure. So whatever it was easy. That means a patient of chronic stable angina, long-standing heart disease, now develops congestive heart failure. Okay, there are either signs of congestive heart failure. Here you can see there is a right-sided heart failure, peripheral edema, hepatomegaly due to congestion of liver, raised JVP is usually seen. Okay, so which of the following drugs will increase the life expectancy? Okay, some people are saying there was longevity in the question. Some people are saying life expectancy. Both of them are the same thing. Okay, longevity or life expectancy is one and the same thing. And as we have discussed, that usually life expectancy or longevity, usually in a patient of heart failure, is increased by beta blockers. And why by beta blockers? As we know, usually in beta blockers, they will decrease the heart rate. In beta blockers, on chronic heart failure, we can give beta blockers. In acute heart failures, beta blockers are contraindicated, right? That we know. So in chronic heart failure, usually beta blockers are given because they increase life expectancy or longevity, because they will decrease the heart rate, and therefore the myocardial oxygen demand is decreased. Okay, as heart rate is decreased, therefore myocardial oxygen demand decreases, and therefore it will help the heart or myocardium sustain longer without less amount of oxygen. Okay, so beta blockers was one of them, but in option no beta blocker was mentioned, no LOL was mentioned in the option. Okay, so another usually drugs that are preferred in cases of congestive heart failure, as we know, okay, that is option B. Sorry, that is usually calcium channel blockers and ACE inhibitors. Okay, we give either calcium channel blockers or ACE inhibitors, right? And here the more likely answer to this question would have been option B, lisinopril. That is a ACE inhibitor. ACE inhibitor are also used for increasing life expectancy or longevity in a patient of congestive heart failure. Okay, torsemide is given for. Torsemide is a loop diuretic, guys. As we know, torsemide is usually given to overcome the edema, either the peripheral edema or the pulmonary edema in a patient of CHF. Okay, it will not increase the life expectancy. Why nifedipine I am ruling out? याद रखना nifedipine के बारे में we discussed about calcium channel blockers. One thing, guys, okay, calcium channel blockers के बारे में और nifedipines, mainly the dihydropyridines I discussed. Usually they will increase the heart rate, and if they increase the heart rate, guys, therefore they will increase the myocardial oxygen demand, and rather they will worsen the status of the patient, and therefore they will not help in recovery or increasing life expectancy of the patient. Okay, so yaad rakhna, we give them usually calcium channel blockers are usually avoided in cases of acute CHF. You can give it on long term, but usually avoided in cases of CHF patient. ठीक है ना? So ACE inhibitors के साथ the other drugs which are given, either you can replace ACE inhibitors with ARBs, angiotensin receptor blockers, or Zartan drugs. Along with that, you can add nephrolysin inhibitors, drugs like sacubitril. Okay, nephrolysin inhibitors. ARNI ये मैंने दिया था पूरा. I've taught you in this cardiovascular system. ARNI, angiotensin receptor blocker or ACE inhibitors, along with nephrolysin inhibitors. ठीक है? So here the answer would have been lisinopril. Digoxin increases the contractility of the heart. It increases the inotropic action of the heart. It is an inotrope. It will not increase the life expectancy because it has no role or as such on the heart rate of the patient. Question number 79, guys. A patient has dyspnea, that is breathlessness, and syncopal attacks. Okay, the patient is falling unconscious, or maybe the patient is having syncopal attacks. His vitals are BP is 80 by 40 mm of Hg. So this is a clear indication why the patient is having syncopal attacks or syncope, because the BP is very low. Okay, rather the patient is hypotensive. So the first funda, the patient is suffering from hypotension, and there are diminished heart sounds. So some are saying soft heart sound, some are saying diminished heart sound. Okay, nothing but the muffled S2, S1 or S2 sounds. That is muffled diminished heart sounds or muffled S1 and S2 sounds, along with the absent Y descent and GVP. And why Y descent is usually absent in GVP? Because the heart is not able to contract properly, and therefore the ejection is not proper. So please remember what is happening. There is some fluid which is surrounding the heart in the pericardial cavity. This fluid pressure is so much that that it is crushing the heart. And if it is crushing the heart cannot properly contract. If it cannot properly contract, therefore the ejection would not occur properly. Agar ejection nahi hoga, ejection is less, ejection fraction is less, cardiac output would be less. And as cardiac output is less, therefore the BP would be low. That means the patient will land up in hypotension. Along with that, the blood will keep on accumulating usually in the heart, and therefore the pressure in the jugular vein would rise, and that will lead to a rise in the jugular venous pressure. Okay, there would be rise in the jugular venous pressure, but this rise, as we have discussed, it is a non-pulsatile rise in jugular venous pressure. ये मैंने बहुत बार बताया है. SVC, thrombosis, and cardiac tamponade are only the two conditions where there's a non-pulsatile rise in the GVP. Okay, and on GVP we can see an absent Y descent. I have given the table for GVP changes, right? So this is a classical example of the Beck's triad. Okay, so these are the classical features of Beck's triad. There are three features in Beck's triad. First is hypotension. Second is usually diminished or muffled heart sounds. And third is a non-pulsatile rise in GVP, which they have not given directly. Rather, they have given the GVP finding, that is absent Y descent. So this is the classical case of option D, cardiac tamponade. Okay, please remember this. Constrictive pericarditis mein, there would not be absent Y descent. Rather, there would be a steep X and a steep Y. Okay, there would be a steep X and a steep Y in cases of constrictive pericarditis when there is calcification of the pericardium. Okay, so that also I have discussed with all of you. Acute pericarditis, the patient would have a pain, a chest pain. Okay, very excruciating chest pain usually in this area. That is what is a feature of acute pericarditis. Along with that, definitely sometimes there can be fever in the patient as well. Okay, congestive heart failure, there would have been signs of heart failure. Like if there is the right-sided heart failure, there would have been elevated JVP definitely. But along with that, the patient would have hepatomegaly, there would be peripheral edema in the patient, okay, all of these. Whereas if it would have been a left-sided heart failure, there would be features of pulmonary edema as well in the patient, right? No issues with this. This was a classical case of Beck's triad. Next, question number 80. A chronic alcoholic patient with chronic liver disease. Some people are saying there was alcoholic cirrhosis. So whatever it was, it is one and the same thing. So alcoholic cirrhosis or chronic liver disease in a chronic alcoholic patient now develops sudden onset hematemesis. Hematemesis is blood and vomiting. Now develops sudden onset hematemesis. Which of the following is the most likely cause? So as I've discussed, the complications of cirrhosis, as I always told you, okay, there are multiple complications of cirrhosis, but usually one among the most common complications is portal hypertension. And if the patient develops portal hypertension, there would be features like splenomegaly in the patient. Apart from that, there would be dilatation and tortuosity of the portocaval anastomosis. And portocaval anastomosis हमने जगह भी discuss की थी. कहाँ होता है? It is usually in the lower part of the esophagus. It is usually in the anal canal. And if there is portal hypertension, rise in the pressure of the portal vein, definitely there would be rise in the pressure in this portocaval anastomosis also. So there would be dilated veins usually in the lower part of esophagus known as esophageal varices, whereas in anal canal it would lead to hemorrhoids. Okay, and if the pressure rises so much, when it is usually 10 mm of Hg, there would be varices. But if it is more than 12 mm of Hg, the pressure, then there would be bleeding from these varices. Okay, so here the patient would have portal hypertension, which is developed due to alcoholic cirrhosis, and now the patient is having hematemesis, usually due to option B, esophageal bleeding varices. बहुत सारे लोगों ने मुझे Mallory-Weiss syndrome का recall दिया था. Please remember, guys, I have discussed with all of you. तुम्हारे दिमाग में घुस के बैठा था Mallory-Weiss. You were thinking in terms of Mallory-Weiss if alcoholic comes in front of you. As I always told you, for Mallory-Weiss or Bohr-Haave syndrome, for both these conditions, the important thing which would have been mentioned was a chronic alcoholic patient now presents to you after a binge drinking episode. Now presents to you after a binge drinking episode. बहुत ज़्यादा शराब पी ली उसने, and along with retching or vomiting episodes. Okay, along with retching or vomiting after a binge drinking episode. Why? Because retching or vomiting will increase the pressure so much that would lead to tear usually in the lower part of the esophagus, and that can cause bleeding. And that is what is Mallory-Weiss syndrome. Or if the retching or vomiting is so much that there is a complete rupture of the esophagus in the lower part, and that can lead to a transmural rupture of esophagus leading to Bohr-Haave syndrome. There would be chest pain in the patient. There would be subcutaneous emphysema in the patient along with vomiting. That is a macular striate of Bohr-Haave syndrome. Both of these features were not present, right? No binge drinking, no retching or vomiting episode. So किस हिसाब से तुमने Mallory-Weiss tier mark किया? I'm not sure. Okay, so if you have marked Mallory-Weiss, please remember there should have been these two features. I'm not still sure. Definitely you were the ones who gave the exam. You might know it better. So अगर ये दो चीजें थी, then only your diagnosis would be Mallory-Weiss. Otherwise, as I always told you, the patient of cirrhosis is more likely to develop some a complication of portal hypertension, hepatorenal or hepatopulmonary syndrome. Okay, so here the answer was esophageal bleeding varices. As we have already discussed, for bleeding varices, the drug of choice is usually IV octreotide. For prophylaxis or prevention, it is IV propranolol, and the best drug for bleeding esophageal varices is terlipressin. Okay, moving further. Question number 81 says J wave is seen in. So as I've already drawn the ECG in front of you, so this is the ECG wave, this is the P wave, this is the QRS complex, and this is the T wave, right? So at the end of the S wave, as I told you, so this is the Q, this is the R, and this is the S wave. So at the end of the S wave, this point is actually called as the J point. This is known as the J point. And कहाँ पे discuss किया था हमने? We discussed this in the PJ interval of Wolff-Parkinson-White syndrome, right? जब हमने WPW discuss किया था, I told you the end point of S wave is known as the J point. Okay, so this from start of the P wave till end of the J wave, it is usually the PJ interval. ठीक है? So at least अगर किसी को J point नहीं पता था, so we have discussed it in WPW. The end of S wave is the J point. And अगर if we are able to see any wave at the end of this, okay, at the J point, if we are able to see any wave, this is what is called as the J wave. And J wave, also known as the Osborn wave, it is suggestive of option A, hypothermia. J wave or Osborn wave, as we discussed, it is suggestive of hypothermia. So J wave or Osborn wave on ECG is suggestive of hypothermia in the patient. Moving further now, question number 82. A female patient was having fever for the past 3 days and neck stiffness. So a lumbar puncture was done. As we know, fever, projectile vomiting, headache, and neck stiffness are the classical features of meningitis in a patient. So definitely, if the patient was having all of these features, we were suspecting meningitis in the patient. And if the patient was having meningitis, then a lumbar puncture was done. So lumbar puncture pe findings kya dikhe? So CSF findings are usually opening pressure is increased, there is a white cloudy appearance of the CSF. The neutrophils are predominantly seen in the CSF, and the CSF glucose is 15 milligram per deciliter and proteins are 100 milligram per deciliter. Okay, so all of these features were given. So with the clinical features itself, we were suspecting meningitis. To confirm our diagnosis further, we performed a lumbar puncture. We obtained CSF. In CSF findings, what was seen first is increased opening pressure. As we know, I have made a table for meningitis for all of you. All the 4 types of meningitis I have discussed. And we have made the table together almost 2 or 3 times, right? So I have told you, opening pressure is increased in all types of meningitis, whether it is bacterial, fungal, tubercular, or viral. In all types of meningitis, 2 things would be increased. First is the opening pressure, and second would be the proteins. So proteins and opening pressure are elevated in all types of meningitis. No issues with this. Proteins, as we discussed, they are normally 15 to 45 milligrams per deciliter. Here you can see the value of proteins in CSF is 100 mg per deciliter. So definitely the proteins are elevated. So both of these cannot give you a hint. They can only tell you if the patient is suffering from meningitis or not. So with this, definitely along with clinical features, we can make a diagnosis patient is suffering from meningitis. All the options are meningitis only. Then next, you need to look for the appearance. Here the patient was having a white cloudy appearance, or sometimes we refer it to as the turbid appearance. Okay, so white cloudy or turbid appearance is usually seen in cases of bacterial meningitis or sometimes in cases of fungal meningitis. But in viral meningitis, the CSF is usually having a clear or a colorless appearance, first thing, right? Whereas turbid appearance is suggestive of either bacterial or fungal meningitis. So tubercular में कैसा appearance आता है? Tubercular में there is somewhat white appearance, but usually it is characterized by a cobweb coagulum, which was a question in NEET PG this time. So cobweb coagulum अगर बनता है in CSF, then that is suggestive of tubercular meningitis. Cloudy है, so your 2 options that you need to think of is bacterial or fungal meningitis. Moving further, neutrophils are predominantly present in CSF, and as I told you always, the cells in the CSF will decide which type of meningitis it is. Okay, so please remember, all other types of meningitis will have lymphocytes in it. Okay, all other types of meningitis will have lymphocytes in it, except one, that is bacterial meningitis, and which will have neutrophils. So if neutrophils were predominantly seen in the CSF, no other option except for bacterial meningitis would have been your answer. Lymphocytes are usually present in all the other 3 types of meningitis. Tubercular meningitis contains more than 100 lymphocytes. Viral meningitis contains usually 50 to 500 lymphocytes, and fungal meningitis contains usually 10 to 20 lymphocytes. Okay. Apart from that, CSF glucose is usually a hint. That is easy, because in viral meningitis, the CSF glucose is absolutely normal because viruses do not use glucose. Okay. In fungal meningitis, the CSF glucose is low. In tubercular also it is low. In bacterial, it is definitely low. Okay. So glucose would not have been a hint, a proper hint, but cells would definitely the diagnostic feature for this condition. Okay. Moving further, question number 83. A family member is volunteering for blood donation for a person with a road traffic accident. So maybe there was a huge blood loss in a patient of RTA and he went into hypovolemic shock or maybe a surgery, and now he needs some blood. Therefore, a family member was volunteering for blood donation. Before giving blood transfusion, which of the following is not tested for? So we have discussed about blood donation in surgery also. Faculties would have also discussed it. So which among the following is not discussed, not tested for before a blood transfusion? So here we know HIV-1 and HIV-2 are tested definitely before giving a blood transfusion. Hepatitis B and hepatitis C are also tested before a blood transfusion. And one more test that is done before a blood transfusion, that is VDRL. And VDRL is usually done for syphilis. So all of these are usually tested prior to a blood transfusion, but hepatitis A is not tested prior to blood transfusion. Q, because as we know, hepatitis A and hepatitis E usually are transmitted by fecal-oral route. Okay, hepatitis A and E are usually transmitted by fecal-oral route and not by blood, parenteral, or sexual route. Okay, hepatitis B, C, and D are usually transmitted by parenteral, sexual, or blood route. No issues with this, anybody? So I hope this was a pretty straightforward one again. Question number 84 now. A 50-year-old patient presents with palpitations, episodic headache, and sweating episode. A classical triad that I've discussed, and as I told you, always important and one of the favorite questions of examiner. Classical triad of pheochromocytoma. There is palpitations in the patient. There is episodic headache, and this episodic headache is usually due to episodic hypertension. Episodic hypertension क्यों होता है? Because whenever there would be release of catecholamines from the tumor, then and then only the patient will have hypertension, and that time only the patient will suffer from headache. So episodic headache or episodic hypertension, second feature. And third feature is excessive sweating, that is diaphoresis. This is the classical triad. So here definitely the diagnosis would be pheochromocytoma. Okay, so pheochromocytoma was a clinical diagnosis of mine. Let's confirm it further. So workup shows a small left-sided suprarenal mass. Definitely, as we know, pheochromocytoma is nothing but a tumor which arises from the adrenal gland or the suprarenal gland. Okay, and it is the tumor of the adrenal medulla, from where the catecholamines are released. Epinephrine, norepinephrine, okay, along with dopamine, all of these catecholamines are released from the adrenal medulla. So if there is a tumor of this adrenal medulla, that is pheochromocytoma, definitely the patient will have features of palpitations, diaphoresis, and episodic headache. Okay? So the diagnosis is confirmed as pheochromocytoma. For confirmation further, because as I've always discussed, radiological investigations, those are not confirmatory. Okay, it can be hyperplasia also, it can be a tumor also, it can be any cortical tumor also. You are not sure. So to confirm our diagnosis further, we need to do some lab test. And which of the following would be done for confirmation? As I always told you, बहुत लोग mistake करते थे. So investigation of choice, if they ask you, then the answer would have been plasma fractionated metanephrine. Okay, the best investigation, the best lab workup that we can do for confirmation of pheochromocytoma is plasma fractionated metanephrine levels. But यहाँ पे plasma fractionated metanephrine levels इस बार उन्होंने दिए नहीं. Rather, they gave you some screening test. And as I told you, screening tests are usually urinary levels of catecholamines. You can check for urinary levels of catecholamines. Apart from that, you can also go for, if that is also not an option, then you can go for urinary levels of vanillin mandelic acid. Okay, vanillin mandelic acid, VMA levels. So urinary levels of VMA can be checked as a screening test for pheochromocytoma. Okay, better one is catecholamine levels. Nahi hai option mein to VMA, and investigation of choice is definitely plasma fractionated metanephrine levels. Koi dikkat nahi hai isme. Important. Now, some of you are confused ki serum 5-HIAA. So serum 5-HIAA levels, we have discussed this question classically. This is usually done in cases of, this usually is assessed in cases of serotonin syndrome, when there is excess of serotonin. Kyun? Because VMA is a metabolite of dopamine. VMA is a metabolite of catecholamines or dopamine. So catecholamines or dopamine, when they are metabolized, they will lead to production of VMA. Or agar VMA levels zyada hai urine mein, that is suggested that definitely the levels of dopamine or other catecholamines are high in blood. Okay? So that is the indicator. Therefore, it is a screening test and not the investigation of choice. Whereas 5-HIAA, this is actually a metabolite of serotonin. So it is usually a feature of serotonin syndrome when there will be elevated levels of 5-HIAA in the serum. Okay? And serotonin syndrome, as we know, it is commonly associated with carcinoid tumors. And this question we have discussed. The patient was having a neuroendocrine carcinoid tumor, and then he developed flushing. There was a headache. There was the cutaneous flushing, which was seen, redness was seen, and that was due to serotonin, right? And one of the tests that can be done for carcinoid tumors or serotonin syndrome is 5-HIAA. Myoglobin levels are definitely done in cases of rhabdomyolysis. Here there was no rhabdomyolysis, no traumatic injury to the patient. Trypsin levels are usually done for pancreatitis in the patient. Okay, trypsin is the one which helps in fat absorption. Moving further, guys. Now, question number 85. A known hypertensive patient is brought to the emergency room with palpitations and breathlessness. On examination, the blood pressure is 210 by 120 mm of Hg with development of encephalopathy. Right? As we know, the patients of hypertension, if there is increased blood pressure, the patient can develop hypertensive encephalopathy, and there would be altered sensorium and all of that. Okay, so all of the following can be given as treatment options, except so constant treatment option nahi hai in this patient, right? So hypertensive patient brought with palpitations and breathlessness, that means he is suffering from heart failure now. There is a hypertensive crisis, so there is end organ damage, and one of the end organ apart from heart is definitely the brain. So due to this excess blood pressure, that is 210 by 120 mm of Hg, the patient has developed encephalopathy or hypertensive crisis. So all of this can be given as treatment option, but except which cannot be given as a treatment option, right? So if the patient is a hypertensive, in brain usually what can happen, there would be a due to hypertensive crisis or hypertensive emergency, the patient can develop an intracerebral hemorrhage. And agar patient mein intracerebral hemorrhage hai, in cases of active cerebral hemorrhage or active cerebral bleed, as I told you, the one drug which is absolutely contraindicated is option A, IV mannitol. In active cerebral hemorrhage, IV mannitol is absolutely contraindicated because it will lead to sudden decrease in the ICP or intracranial pressure, and that can lead to herniation of the brain in the patient. Okay? So IV mannitol is not recommended, so that could not be given in the patient. Yes, nicardipine, rather it is the drug of choice for hypertensive crisis और intracerebral hemorrhage. ये hemorrhages बहुत बार discuss किए थे. Please let me know if there was any other question of intracranial hemorrhage. Some people are recalling EDH. So please let me know if EDH was one of the questions. ठीक है? Then IV esmolol, definitely esmolol, that is a beta blocker. It is a short-acting beta blocker, shortest acting rather. It will decrease the heart rate and it will maintain the cerebral perfusion pressure. So it can also be used. Sodium nitroprusside, definitely it is used in cases of hypertensive crisis, right? So in hypertensive crisis, the drug of choice is sodium nitroprusside, usually according to the JNC 8 guidelines, whereas according to Harrison, it is hydralazine. अगर नहीं ऑप्शन है तो nicardipine. ठीक है? Moving further now, question number 86. A patient presents with complaints of morning time productive cough that is yellow in color, that increases on turning from left to right side. Which of the following lung diseases is likely to be present? So I hope this was easy. A productive cough with sputum which is present, it is suggestive of some pyogenic infection or some long-standing bacterial infection in the patient. Now, which of the following lung diseases is likely to be present? The X-ray has been given over here. So in the X-ray, if you can see on the right side, there is usually dilatation of the duct, and this dilatation of the airway will give you which appearance? The dilatation of the airway will give you a tram track appearance. And as we have discussed, damage and dilatation of the larger airways, giving a tram track appearance on HRCT or on chest X-ray, it is likely suggestive of a cylindrical bronchiectasis, right? It is suggestive of option B, bronchiectasis. As we discussed about bronchiectasis can develop in multiple patients like cystic fibrosis, Cartagener syndrome, okay? So in all these patients, it may be in chronic bronchitis patient also it can develop. So there would be recurrent pyogenic or pus forming infection, and that would lead to a yellow colored or a whitish sputum in the patient, and excessive sputum production would be there. There would be bronchoria, foul smelling sputum in the patient, which is usually increased in morning time. Okay, this is a classical case of bronchiectasis. Lung cancer, the patient would have other symptoms like hemoptysis, also blood in sputum. There can be excessive sputum, but blood in sputum is a characteristic feature, along with chronic weight loss. Maybe a smoking history would have been given. Okay, so lung cancer can be ruled out with this. Emphysema, there would be hyperinflation on the chest X-ray. On both the sides, the lungs would be hyperinflated. Zyada bade lungs dikhenge and flattening of diaphragm would have been seen, which is not seen in this condition. Again, pulmonary embolism, the three signs we have discussed about pulmonary embolism were the focal oligemia known as the Westermarck sign, a wedge-shaped opacity which was seen known as the Hampton-Ham sign. Okay, along with that, definitely a right dilated descending pulmonary artery known as the Pallas sign. Here, you can confuse this tram track for that Pallas sign, but please remember, usually in pulmonary embolism, the patient would not have cough with productive sputum. Okay, productive cough with sputum nahi hoga. Rather, the patient will have respiratory distress after a long flight or maybe prolonged immobilization. That was the case. So here the diagnosis is bronchiectasis. Question number 87, a smoker male patient who has difficulty in swallowing, that is dysphagia, and difficulty in breathing, that is dyspnea, is most likely to develop which of the following? So we know usually smokers are at a more likely risk of developing lung cancers, right? And which among the following lung cancer a smoker would be commonly developing? So a smoker on long-standing smoking will more likely develop or more commonly develop option A, squamous cell carcinoma of lung, right? As we know, as we have discussed, the most common lung cancer associated with smoking is squamous cell carcinoma, but the most strongly associated cancer associated with smoking is small cell carcinoma or old cell carcinoma of lung. Okay, so most strongly associated agar hota, then the answer would have been small cell or old cell carcinoma of lung. But agar most commonly associated or most likely pucha hai, then the answer would be squamous cell carcinoma. And most of you have given a recall that small cell or old cell was not even there in option, so no issues. Okay, adenocarcinoma, as we know, it is the most common lung cancer overall, most common lung cancer in females, and most common lung cancer in non-smokers as well. No issues with this, anybody? Moving further, now discussing about question number 88. Which type of joint helps in the shown movement? Which movement is seen over here? So most of the people have said that wrist joint ka image diya hua tha. So this is the wrist joint image, and they have marked at the radioulnar joint, rather the inferior radioulnar joint, and they asked you which movement is usually, some people are saying which movement is seen. So usually which movement is seen? So we know it is the supination or pronation movement. Okay, so supination or pronation movement usually occur at the superior or the inferior radioulnar joint. This is supination, this is pronation, right? So supination or pronation movements usually occur at the superior and inferior radioulnar joint, whereas the middle radioulnar joint, jiske bare mein kal question discuss kiya, that is a immovable or a fibrous joint, right? Due to the interosseous membrane, syndesmosis. Okay? Whereas the superior and inferior radioulnar joint, here one bone moves around the axis of another bone. And ऐसा type का जो joint होता है, when one bone moves around the axis of another bone, this is what is known as the option A, pivot joint. This is what is known as a pivot joint. ठीक है? When one bone moves around the axis of another bone, this is the pivot joint, superior and inferior radioulnar joint, or the first or second vertebral joint. That is the axis articulating with the atlas. So the dens of the axis articulating with the atlas. Okay? So all of these are pivot joints. No issues with this, anybody? Hinge joint is usually your elbow joint. Okay? Only one directional movement is possible in this. Okay? Question number 89 now. What is the vertebral level of the arrow mark structure? So the arrow was marked at the umbilicus, and they are asking you what is the vertebral level of the umbilicus. So we know usually umbilicus, as I told yesterday also while I was discussing about the planes, umbilicus lies at the junction of L3 and L4 vertebra. Umbilicus usually lies at the junction of L3 and L4 vertebra. Therefore, if you know the level of umbilicus, you know that the line joining the two tubercles, the two iliac tubercles, known as the transtubercular plane, it will lie at the level of upper border of L5 vertebra. Whereas the line joining the two costal margins, that is the subcostal plane, usually it will lie at the upper border of the L3 vertebra. Whereas the one which goes from the pylorus of the stomach, known as the transpyloric plane, it will usually lie at the level of lower border of L1 vertebra. So ये सब discuss कर लिया था मैंने कल. So here umbilicus usually lies at the junction of L3 and L4 vertebra. जो बाकी question discuss किया था हमने, that was T10. That was the dermatome, guys. Please remember, T10 is the dermatome, the innervation for your umbilicus. Okay, so appendix and the umbilicus are usually innervated by the same dermatome, and that is T10. Okay. Moving further now, question number 90. A patient on mountain at 5,000 meter is having headache, there is dizziness and cerebral edema. Which of the following findings indicate development of high altitude cerebral edema? So whenever you know, when the patient rapidly climbs on a mountain, okay, usually more than 2,000 meter, the patient is more likely to develop a high altitude cerebral edema, and the patient can have headache, dizziness, okay, altered sensorium, all of these. So here, which of the following indicates development of high altitude cerebral edema? Definitely it was easy. Increase in blood pressure is not an indicator. Retinal hemorrhage is not an indicator. Desaturation and altered mentation, most of you are confused. So cerebral edema hai, so definitely the patient will have altered mentation or altered sensorium. Okay? There would be confusion, there would be drowsiness, disorientation. All of these features can develop in the patient. Okay? So altered mentation is usually likely suggestive of a high altitude cerebral edema in the patient. Okay? Not desaturation. Okay? Desaturation का और question था. Please give me a recall क्या था वो exactly. Question number 91 now. A 60-year-old man presents with a 2-month history of weakness and pallor. Per abdominal examination shows moderate splenomegaly, and a peripheral blood shows hemoglobin, which is 10 grams per deciliter, leukocytosis, that means elevated levels of WBCs, and platelets, which is 3 lakh per cubic millimeter, near normal platelet count. Peripheral smear shows metamyelocytes, which are 15%, promyeloblasts, which are 30%, myeloblasts, which are 45%. Which of the following is the diagnosis? Okay? So usually, agar it is an elderly patient and having myeloblast or myelocytes, definitely you can easily rule out ALL, acute lymphoid leukemia या lymphoblastic leukemia तो है ही नहीं है. Okay, first thing to rule out is the age of the patient. Second, myelocytes है, and myelocytes and metamyelocytes है. Definitely you can rule out CLL also with the same funda, because CLL में there would be lymphoblasts or lymphocytes, not myeloblasts or myelocytes. ठीक है? So you are left with either CML or AML. Both of these are usually seen in adult or elderly age group. Okay? AML is common in 50 to 60 years of age group, whereas CML is common in around same age group, like 50 to 60, 70 years of age group. Okay? So here they have not given you any genetic translocation like last time they gave you for Philadelphia chromosome. So that then the diagnosis would have been easier. Neither they gave you any peripheral blood smear which is showing all rods, then the diagnosis would have been directly AML, easier. Neither they gave you myeloperoxidase positivity. Okay, so diagnosis would have been AML. But यहाँ पे, as I always told you, AML और CML के बारे में be cautious, because CLL and ALL are easy. ALL बच्चों में, CLL बहुत elderly patients में. Okay, CLL में smooth cells दिखेंगे, ALL में usually you'll find large lymphoblast. ठीक है? Usually in both of these conditions there would be lymphadenopathy and all of that features would be seen. Pancytopenia would be there. bone tenderness would be there. But CML or AML, there is a confusion. Okay. So as I told you, age could not be a deciding factor solely. Apart from that, the patient is having weakness and pallor. Pallor is usually due to the decrease in hemoglobin. That means the patient is landing up in anemia. Weakness is also due to the same one, which is explained by anemia. There is moderate splenomegaly. This would have been a important indicator. See, please remember, guys, hepatosplenomegaly can be seen in cases of AML, but moderate splenomegaly is a characteristic. Moderate or severe splenomegaly is a characteristic feature of CML. Okay, first funda, the first keyword that directs you to the CML diagnosis. Peripheral blood smear, hemoglobin कम है, leukocytosis है, दोनों में देख सकता है. Platelets normal है. Peripheral smear showing you metamyelocytes. Sites are not seen in cases of AML, guys. In AML, as there would be only immature myeloblasts which are seen. Okay, so promyeloblast and myeloblast would have been high, more than 20% in AML. But metamyelocytes in such a high amount are not a feature of AML. Rather, they are only seen in CML cases. Okay, so यहाँ पे there is a combination. There are metamyelocytes, there is promyeloblast, whereas there is myeloblast. So तुम तो बोलोगे sir. In usually we have discussed that blast cells are less than 20% in cases of chronic leukemias. But I told you in CML, guys, there are 3 stages of CML. There is a chronic stage, jahan pe blast cells are usually less than 10% or 15%. Then there comes a accelerated phase when the blast cells are around 10 to 15%. And then there comes a blast crisis stage when, in cases of CML, the blast cells would go beyond 20%, right? ये blast crisis के stage हमने discuss की थी. So here the patient is in the blast crisis stage of CML. So diagnosis is more likely to be CML. I know this would have been difficult to diagnose, but at least it was not so much difficult as well. Moving to question number 92, a patient met with a road traffic accident and was presented to emergency. The GCS, Glasgow Coma Scale or score, was assessed to be 10. What does this Glasgow Coma score imply? I hope सबको अम्मा याद आई होगी जो emergency में आई थी तुम्हारे पास. Right, so we have discussed Amma in great details. Glasgow Coma score के लिए, and Glasgow Coma score we know the minimum Glasgow Coma score is 3, and if the patient is having a GCS of 3, that means the patient is brain dead. Whereas the maximum Glasgow Coma score is 15. If the patient is having a GCS of 15, either the patient would be normal or the patient will be suffering from mild head injury. So mild head injury is said when the patient has a GCS of 13 to 15. Moderate head injury is said when the patient has a score between 9 to 12. Okay? And severe head injury said when the patient is having a score of 3 to 8. Okay, na? No issues with this, anybody? So here the score was 10. That means it lies between 9 to 12. So the patient was having more likely option B, moderate head injury. No issues with this, anybody? I hope this was easier. Moving further. Question number 93 now. If I talk about question number 93, it states a 25-year-old male who is trying to have a baby for last 2 years is found to have azoospermia. That means absence of sperms in the semen. Okay, so azoospermia hai. Physical examination shows scattered pubic hair, scattered or sparse pubic hair or absent pubic hair sometimes. And pubic hair, as we know, they are a feature of secondary sexual characteristic. Okay, so the secondary sexual characteristics are usually absent or sparse in this patient. Okay, along with gynecomastia and hypogonadism. And this hypogonadism is actually causing infertility in the patient, right? So hypogonadism is azoospermia, and finally the patient is having infertility issues. What is the likely diagnosis? Easy. अगर तुमने male देखा होता, as we know, usually Turner syndrome is 45XO. Okay, so she is a female presenting to you with primary amenorrhea. Easily ruled out. Okay, short stature and all of that. Next, moving further, it was Down syndrome. Down syndrome. Here the patient would not present to you with hypogonadism, gynecomastia. Rather, it would be a child presenting to you with intellectual disability, sandal gap, simian crease, epicanthic fold, pseudo squint, all of that features. Okay, na? So easily ruled out again. Edward syndrome, it is trisomy 18. Here the child presents to you with polydactyly, overlapping of fingers, crowded fingers. Apart from that, the child can have rocker bottom feet. Okay. So here the diagnosis was much easier. It was option A, Klinefelter syndrome, which is the karyotype of 47XXY. So okay, one X chromosome is extra in this patient, 47XXY. And Klinefelter syndrome, it is usually a male presenting to you with infertility issues or hypogonadism issues along with gynecomastia. Because of one more X chromosome, the patient is feminine in nature. Okay, there would be increased breast enlargement leading to gynecomastia. There would be scattered or absence of pubic hairs due to decreased levels of testosterone in the patient. Okay. Apart from that, the patient will have azoospermia for the same leading to infertility. Okay. The patient will have a tall stature, Okay, there would be streak or testis usually, maybe sometimes there would be undescended testis or cryptorchidism in the patient. Okay? So all of these features are Klinefelter. Moving further, question number 94. All of this we have discussed. Each and every genetic syndrome I have discussed in OBG as well as pathology. Almost everywhere I've discussed this. So I don't think so there would have been any issue answering this. Question number 94. A boy sustained a bike accident and presents to the emergency room with pain and swelling around the knee joint. X-ray of the knee joint has been given below. Here on the knee joint X-ray, you can see, usually I told you, this was a PYQ. Usually they like to ask something about the patella. Okay, so here they have given that the patella or the kneecap that is seen in front of the knee joint, it is usually fractured. Okay, so here definitely it is a fracture of patella. And as we know, fracture of patella, we discussed in PYQ, in ortho, in anatomy, almost all sessions, that fracture of patella is only and only treated by tension band wiring. It is only treated by tension band wiring. It is not usually treated by a POP cast. Okay? If it is a comminuted fracture, when patella goes into pieces, then definitely it is to be treated with tension band wiring. Agar ye option mein tha, nahi tha, to wire fixation was there an option. Any of those would have been your best answer. Conservative management is not done for patella fractures. Apply POP cost. Union is not much the chances of union are not so good with patella fracture. So if it is comminuted, you need to go for wire fixation or tension band wiring. Okay, no issues with this, anybody? Moving further. Question number 95. A speech gathering on a particular topic with 4 to 6 experts on the stage is which mode of health communication? So I hope we have discussed about didactic, that is one way mode of health communication, and we discussed about Socratic, that is two-way mode of health communication. Har ek health communication mode I have discussed in great details. Even Neha ma'am would have discussed it, right? So we have discussed about all the Socratic modes. That is usually a two-way communication. The best one is interpersonal communication or one-on-one communication between a doctor and patient. But the others we have discussed, it is a workshop when there is a Q&A session, usually after you teach something to the audience. Then there is demonstration for ORS preparation. There is symposium, or usually there is a seminar or conference when there are speeches, and after that there is a Q&A session. Okay, where there is a focus group discussion, we discuss there are usually a sociogram which is drawn. One of them is a leader and one of them is the recorder. Okay, so this kind of a picture which is drawn, that is a sociogram. Last time there was a question on number of audience, how much are there, the ideal or minimum number of audience in a focus group discussion, that was 6 to 12. But this time they asked you that there is a speech gathering on a particular topic, maybe there is some particular health topic, and on that there are 4 to 6 experts who are discussing about that particular topic. So this is nothing else but option B, panel discussion, right? After panel discussion, also usually there is a Q&A session. So it is also a Socratic or a two-way method of health communication. There is no set order of speeches, unlike a seminar or conference in this. So जो TV पे debate होती है ना हर रोज रात को, that is nothing but a panel discussion. Though those are not experts, but yeah, we consider it to be a panel discussion. Okay? Moving further, question 96 says Gleason score is used in. So as we know, Gleason score, this was a straight one-liner. Gleason score is used in cases of grading for prostate cancer. It is used for grading for prostate cancer. This was a repeat question. So Gleason score is usually used for grading of prostate cancer. Okay, we know this. Apart from that, usually for appendicitis, we know it is the Alvarado score or the modified Alvarado score, and the mnemonic is the Mantral score. Okay? It is the Mantrals or the modified Alvarado score. Whereas people are saying the other option was pancreatitis. So for pancreatitis, as we know, guys, usually for pancreatitis, it is, we have discussed, it is the Ranson score, okay, which is the clinical severity score, or a Balthazar score, which is a CT severity score. Okay? Whereas Apache score, it is for any of the chronic illnesses. Moving to question number 97, a repeat question. OBG, pathology, medicine, almost everywhere we have discussed this question. Surgery, right? Which among the following radioactive iodine is used in the treatment of cancer? So as we know, for treatment purpose, this was the question I discussed in the PYQ. Same question. Which of the following radioactive iodine is used in the treatment of cancer? You can just watch the PYQ discussion, you will find this question. Okay? So which among the following is used? We have all of you, I know you have marked it right. It is option B, iodine 131, we know. Whereas all other types of radioactive iodine, iodine 125, iodine 123, these are having a shorter half-life, and therefore they are usually used for diagnostic purposes. These are usually used for diagnostic purposes. We have discussed the half-life even of iodine 123, it is 13 hours. Therefore, as due to the short half-life, it is used for diagnostic purposes. Whereas iodine 131, as we have discussed, the half-life is usually longer. It is usually 8 days of half-life. And as we know, it emits which rays? It emits beta rays. And as it emits beta rays, iodine 131, it will destroy the cells of thyroid follicle, and that will usually use that. Therefore, it would be used in cases of thyroid cancer or in cases of hyperthyroidism. No issues with this, anybody? I hope this was a pretty straightforward one. Moving further, a patient delivered a child 6 weeks ago and now presents with pain, swelling, and redness in the breast. This was a classical question, along with increased local temperature. On ultrasound, fluid collection was noticed. So मैंने बोला था, अगर on palpation there is a fluctuant mass or on ultrasound there is fluid collection, definitely that there would be likely pus inside it, and that is a likely diagnosis of breast abscess. मैंने बताया था, if the child is only refusing the feed and the patient is having pain and fullness in the breast, diagnosis is breast engorgement. Along with that, if the patient is having signs of inflammation like pain, swelling, redness at the site, increased local temperature, then definitely the diagnosis would be mastitis along with fever. But along with all these, the patient is having fever, high-grade fever, along with chills. Along with that, on palpation, there is a fluctuant mass in the breast, or maybe the ultrasound shows fluid collection. Okay, that is suggestive of breast abscess. So here the diagnosis was breast abscess. And what is the treatment option for her diagnosis? So IV antibiotics are the treatment of choice for mastitis. Okay. So mastitis, when there is only inflammation, it can be treated with IV antibiotics. But breast abscess, here express milk with moist compress, it is usually, or conservative management, it is usually done for breast engorgement. Okay, it is usually done for breast engorgement. Whereas for breast abscess, as we know, it is incision and drainage along with IV antibiotics should be started to the patient, right? IV, and then you can start the patient on oral antibiotics after 2 weeks. Okay? So incision and drainage along with IV antibiotics or oral antibiotics, depending on the severity, you can decide. कितना severe है वो breast abscess, ठीक है? So incision and drainage along with antibiotics are usually preferred in this patient. No issues with this, anybody? So here the best answer would have been IND, incision and drainage. Moving further to question number 99, a girl was using her sister's contact lenses often. Which among the following condition is most likely associated? Please correct me if the question was similarly framed or not. A girl was using her sister's contact lenses often. So which among the following condition is most likely to develop in this patient? So it is, as we know, contact lens users, the most common corneal ulcer that the patient develops is pseudomonas. The most common corneal ulcer in contact lens users is pseudomonas, but the most specific corneal ulcer in a contact lens user is usually acanthamoeba ulcer or acanthamoeba keratosis or acanthamoeba keratitis. Kuch bhi ho. As we discussed, it is the most painful ulcer among all. It can be of various shapes. It can be ring, nummular, dendritic, anything, as I discussed yesterday. And the drug of choice is PHMB, that is polyhexamethylene biguanide. All of these things I have discussed in ophtha chanting. Shivani ma'am has discussed multiple times. I have discussed it in TNT. So, like QRS session में भी discuss किया था. I don't think so there should have been any issues. Viral पे भी था, acanthamoeba पे भी था. 2 questions were there. Question number 100 now. Which organism can't be grown on artificial culture media? I'm pretty sure Vikas sir would have revised it multiple times. Which among the following organism cannot be grown on artificial culture media? As we know, it is known as option C, Mycobacterium leprae. And sir ने ये तक बताया होगा, Mycobacterium leprae, please remember, it is not grown on artificial culture media. Rather, it is grown on a natural media. Like, for example, the best media that is used is usually a 9-banded armadillo. Okay, the best one to be used is a 9-banded armadillo. But as armadillo is not available in India, it is an Australian mammal. Therefore, in India, we use the footpad of mice. Okay, most commonly we use the footpad of mice. But the best one to be used for culture is 9-banded armadillo. कोई दिक्कत नहीं है. So I hope this was a pretty straightforward one, right? For Mycobacterium tuberculosis, you know the culture media is usually Lowenstein Jensen media, that is your LJ media. Okay, no issues with this. I hope all of you have answered it right. Moving to question number 101. A patient comes to emergency with history of IV drug abuser and developed some infection. Which of the following is the most likely cause? As we have discussed, the most common infection in IV drug abusers usually would be Staphylococcus aureus, right? अगर कुछ नहीं आता, मैंने बोला था क्या किस पे जाओ? Staph aureus पे जाओ. That would be the safest answer, right? So IV drug abusers usually are more likely to develop right-sided endocarditis, or maybe a IV drug abusers are more likely to develop a right-sided endocarditis or a tricuspid endocarditis. Okay? So in this patient, usually the most common cause is usually option B, Staph aureus. Okay, it is Staph aureus. Okay, Streptococcus viridans, as we know, it is the most common cause for SABA, that is subacute bacterial endocarditis. It is not associated with IV drug abusers. Okay, na? Please remember this. Moving further, again, an easy question, straightforward. Which of the following is the causative agent for the given clinical picture? So this given clinical picture kya dikh raha hai? There are small papilla or comedonal lesions which are seen. Okay? These are nothing but acne, right? This is acne vulgaris, the most common type of acne, that is acne vulgaris. We know all the stages of acne. I have discussed it in Dharma chanting. Nisab sir has discussed it multiple times. So acne, we know the first stage of acne or first grade of acne is comedones. The next stage or next grade of acne is papular acne. The third stage of acne is usually the pustular acne. And the fourth or the most severe type of acne is usually grade 4, that is nodulocystic acne, when nodules are usually formed. Okay? So these are the grade four grades of acne. So here it is the stage 1, that is usually a comedonal acne. You call it as a black head or a white head. Okay, na? So that is usually a comedonal acne. And the most common cause of acne, in the name itself, it is evident. It is option A, Propionibacterium acne. Okay, Propionibacterium acne is the most common cause of acne in patients. Comedones ke liye usually we will only give topical retinoids to the patient. We will only give topical retinoids. Papular acne ke liye you will give topical antibiotics along with topical retinoids to the patient. For pustular, here you need to give oral antibiotics along with topical retinoid to the patient. Okay? Topical retinoid. And nodulocystic acne ke liye, it is the most severe version. Therefore, here you need to start oral retinoids, that is oral isotretinoin is usually given to the patient. It is a teratogenic drug. Okay? Moving further, guys, now. Question number 103. A patient who is resident of Bihar came to the OPD with history of diabetes. Okay, history of diabetes and complaining of multiple sinus draining in the foot as shown in the image. So here you can see there are multiple sinuses. Sinuses are one-way opening on the skin. Okay, and they will drain serous discharge or pus discharge usually. Okay, so here there are multiple sinuses in the foot which are draining pus maybe, and they are shown in the image. Identify the condition. This was the image, micro, almost in every other question we have discussed this, right? So this is a PYQ discussion. I've discussed this question almost twice or thrice. Question, right? So it is a classical example of option A, Madura foot, because it is more common is usually in Tamil Nadu. So it is known as the Madura foot. It is commonly seen in farmers. Okay? And it in this, I also told you there was a NEET PG question on this. Like one of the options was true, and the option was it can have a bacterial as well as a fungal cause. So as we know, Madura foot, which is also known as mycetoma, right? It can either be bacterial, where it is called as actinomycetoma, whereas it can be fungal, where it is called as eumycetoma. Eumycetoma, the fungal cause being more severe, and there would be presence of granules. ये भी discuss किया था मैंने. Blackish granules are usually seen in eumycetoma. Red, yellow color granules are usually seen in actinomycetoma. कोई दिक्कत नहीं है इसमें. Gas gangrene, as we know, it is caused by Clostridium balcai or Clostridium perfringens, and there would be ये image तक दिखाई थी मैंने. Definitely there would be color changes which are seen usually. ठीक है? But please remember, in gas gangrene, there the patient will have blebs on the skin or blisters on the skin. Gas-filled blisters. यहाँ पे वैसा कुछ नहीं दिख रहा. यहाँ पे there are sinuses which are seen. ठीक है ना? Chronic osteomyelitis, there is one sinus, not multiple sinuses. याद रखना. Chronic osteomyelitis, as I told you, there is one sinus which is known as cloaca. Right? Dead bone is known as sequestrum. The new bone which is forming around it is known as involucrum. And the sinus which drains, only a single sinus, that is known as cloaca. So it cannot be chronic osteomyelitis, guys. Okay, multiple sinuses is suggestive of Madura foot or mycetoma, and diabetes is usually an immunocompromised state where mycetoma or Madura foot becomes more predominant. Okay. Moving further, and here also the drug of choice is usually LAMP if it is a fungal cause, liposomal amphotericin B, because it is a severe fungal infection. Question number 104. A woman got bitten by a bee. This was a classical question discussed in PYQ and previously also multiple times. A woman got bitten by bee, and the reaction will be mediated by which immunoglobulin? So if a woman is bitten by bee, the patient will have swelling. There would be swelling of lips, vagara. That is what is called as angioedema, right? Along with that, there would be redness and all of that. Sometimes the BP can also fall. And this is nothing but a case of anaphylaxis. And as we know, anaphylaxis is usually which type of hypersensitivity? It is type 1 hypersensitivity. That is allergic or anaphylactic reaction. So here the patient will have anaphylactic reaction after getting bitten by a bee. And which immunoglobulin will mediate type 1 hypersensitivity or anaphylaxis or any allergic reaction? So this is usually mediated by option C, IgE, right? It is also called as IgE mediated hypersensitivity. This also we have discussed. IgM, we know it is seen in cases of acute infection, IgG in chronic infection. Okay, but IgE suggests your allergic reaction or anaphylactic reaction. Okay, moving further. Question number 105. A 35-year-old patient presented with complaints of vertigo on loud sound. ये मैंने phenomena discuss किया था. If you were attentive during the ENT session, I've discussed this phenomenon to all of you. And blowing of nose. What is your diagnosis? Vertigo on loud sound. या चक्कर आना जब ज़्यादा जोर की आवाज सुनते हो. This is nothing but the Tullio's phenomena. I've discussed each and every phenomena of Meniere's with you. Right? This is known as the Tullio's phenomena. When patient falls down on hearing loud sound, that is what is known as Tumarkin's crisis. Okay, when the loud sound appears more loud, okay, patient does not like to go to noisy areas. That is what is known as the recruitment phenomena. And when the patient experiences vertigo on loud sound, that is what is known as the Tullio's phenomena. So Tullio's phenomena, along with usually a tinnitus, fluctuating tinnitus and a fluctuating hearing loss in the patient, is suggestive of Meniere's disease, which is also called as endolymphatic hydrops or glaucoma of ear. Right? Vestibular neuroma mein the patient will have sensory neural hearing loss, a severe or a profound sensory neural hearing loss. What is vestibular neuroma or vestibular schwannoma? It is the 8th nerve tumor. Okay, na? So here the patient will have a severe or a profound sensory neural hearing loss. Okay, the patient will also not like to go to noisy areas, but there would not be any vertigo. Okay, na? Because the 8th nerve is completely damaged. So here the patient will not have any vertigo as such. Okay? So vestibular schwannoma can be ruled out. BPPV बहुत लोगों ने mark किया. Please remember, in BPPV on loud sound the patient does not have vertigo. Patient has vertigo on changing the position. Okay? When the patient changes his position, maybe he was sleeping supine. Now he changes the position towards right side. What happens? Usually the otoconia or the otoliths, they get dislodged. Okay, they get dislodged from the vestibule or the utricle and saccule, and they go into the semicircular canal. Once they go into the semicircular canal, the patient will have nystagmus, rapid nystagmus, and along with that, the patient will experience vertigo. That is what is BPPV. Positional vertigo hai na, uske naam mein hi. So when the patient changes position, then there would be vertigo, not on loud sound. Okay, so BPPV can be ruled out. Labyrinthitis, here the patient would not have any vertigo as such. Okay, in cases of loud sound. Okay, na? Labyrinthitis mein the patient will not have vertigo usually on loud sound. That is what is Tullio's phenomenon of Meniere's disease. Straight away question. Question number 106 now. Which of the following drug is best for urate lowering therapy in tumor lysis syndrome to prevent renal damage? As we know, we have discussed about tumor lysis syndrome, and it is one of the favorite questions of examiner. Tumor lysis syndrome, I discussed a question with you. The patient will have hyperuricemia, right? The patient will have hypernatremia. The patient will have hypernatremia. The patient will have hyperkalemia. Okay, the patient can even have hypermagnesemia, but the patient will have hypocalcemia. Okay, the patient will have hypocalcemia. So all of these features I've discussed. So if the patient is having hyperuricemia, the patient will have renal damage. There can be formation of uric acid stones, which can cause renal damage in the patient. So which among the following is the best drug for urate lowering therapy in tumor lysis syndrome to prevent any renal damage? So here definitely we know the drug of choice for chronic gout or overproducers is allopurinol, which is a xanthine oxidase inhibitor. Okay. Along with that, definitely if the patient is allergic to allopurinol, we give febuxostat. Or if the patient is under-excreter, we give probenecid. Okay. Furosemide can be ruled out because it is a loop diuretic. Okay, yaad rakhna. It is not used. So either allopurinol or febuxostat, you might be confused. But I told you guys, please remember, the best drug for urate lowering therapy is usually enzymes. They are given in cases of very severe gout. So if the patient is having very severe gout or excess levels of uric acid, which are usually seen after tumor lysis syndrome. Tumor lysis syndrome kya hota hai? When you give chemotherapy drug to a patient, the tumor cells are usually destroyed. When the tumor cells are destroyed, excess of metabolites are released into the circulation. One of the metabolites is uric acid, right? When the DNA is damaged, there would be excess levels of uric acid in the serum. So hyperuricemia is due to that reason. And to prevent renal damage due to this hyperuricemia, you need a very good drug which will lower the urate rapidly. Okay, and that the best drug are usually enzymes, recombinant enzymes, as I told you. It is either pegloticase or rasburicase. Okay, so here the option was not pegloticase, rather they gave you rasburicase in the option, so that could be the best therapy for lowering of the uric acid levels. Okay, allopurinol, febuxostat are used in cases of gout. Okay, moving further, question number 107. A 26-year-old female presented with scaly skin. On histopathology, neutrophils were present. What is your diagnosis? I hope this was very easy. If they mention you scaly skin or maybe regions with silvery scales. That is what is suggestive of a papillosquamous disease. And papillosquamous disease हमने दो पढ़ लिए थे. That was either psoriasis or lichen planus. So here lichen planus was not an option, people said me. And even if it was, lichen planus is usually characterized by polygonal plain top papules which are purple in color, right? They are not characterized by usually scaly skin. Scaly skin or silvery scales on a region are usually suggestive of psoriasis, right? They are usually suggestive of psoriasis. And on histopathology, neutrophils would be present in the region. Okay, so that is the classical funda of psoriasis. Here the diagnosis would be option B, psoriasis. Lupus vulgaris is the most common form of skin tuberculosis. Here there would be presence of apple jelly nodules and diastrophy. ठीक है, और वो usually होता है यहाँ पे. There is no scaling as such in seen in cases of lupus vulgaris. If there was pityriasis an option, then definitely there would have been confusion. If pityriasis means scaling, so then there would have been confusion. But pityriasis was not an option. Pemphigus was there. Pemphigus is a vesicular bullous disorder. Here we cannot see scaling or scales. Rather, here we will see fluid-filled blisters, right? Vesicles, if they are less than 0.5 centimeters, more than 0.5, they are called as bullae. So they are seen usually in cases of pemphigus disorders. So pemphigus foliaceus or pemphigus vulgaris. They can be ruled out because here scaly skin is not seen, rather vesicles or blisters are seen. Okay? Psoriasis के बारे में I also told you there were nail findings which came in NEET PG examination. Psoriatic arthropathy and usually nail findings of psoriasis can be remembered by the same mnemonic PSO. For nail findings of psoriasis are remembered by P for pitting of nails known as thimble nails, S for subungual hyperkeratosis, and O for oil drop sign or onycholysis. Whereas psoriatic arthropathy is also remembered with the same mnemonic PSO, where P goes for the penicillin cup deformity, S goes for sausage shaped digits, and O goes for opera glass deformity. Okay? Moving further now. Question number 108. Again, a question on psoriasis. A patient presented with the following regions on the trunk, and here you can see the following regions on the trunk appears like rain drop region. Okay, जैसे कि बारिश की बूंदे या फिर dew drop region, जैसे कि ओस की बूंदे गिरी हुई हो body पे, right, with the erythematous base. So here you can see reddish regions which are appearing like raindrops or dew drops, and such regions I am pretty sure Dr. Vinayak has covered in his image-based session. I have covered it. Apart from that, Nisarg sir has covered it multiple times. So this is raindrop regions or dew drop regions, usually on an erythematous base. This is which type of psoriasis? It is very easy. It's option D, guttate psoriasis. One of the severe forms of psoriasis known as guttate psoriasis. Guttate जैसे region है, ठीक है? याद रखना. Erythrodermic psoriasis. Here the patient will have diffuse reddening of skin. That is what is called as erythrodermic psoriasis. Along with silvery scales definitely, but diffuse redness of skin is seen. पूरी skin लाल हो जाती है. Pustular psoriasis. Please remember, in pustular psoriasis, there is no redness as such. Rather, only a slight red base is seen, but there would be pus-filled regions which are seen. That is what is called as a pustule. Okay? And inverse psoriasis. Usually, we know psoriasis occurs on the extensor aspects, maybe the trunk, the back, the extensor aspects of the lower limbs. But if the psoriasis usually occurs in the flexural aspect, beneath the breast or usually in the forearms, then that is called as inverse or ulta psoriasis. Okay? No issues with this, anybody? Moving further. Question number 109. Neurofibromatosis type 1. Okay, neurofibromatosis type 1 is a hereditary condition. We have discussed about NF1, NF2, both of them. So neurofibromatosis type 1, it is a neurocutaneous syndrome. It is a hereditary condition associated with cafe au lait spots on the skin. More than 6 are diagnostic, as I discussed. Most common lesions of neurofibromatosis. Which pattern of inheritance is seen in the condition? I have given mnemonic for all patterns of inheritance to you. I don't think so there was any issue. Autosomal dominant are remembered by Ravi usually, right? Autosomal dominant are usually remembered by sorry, X-linked dominant are remembered by the mnemonic Ravi, as we know, right? So I hope so all of you are quite aware of that. That is usually Rett syndrome, that is Alport syndrome, then vitamin D resistant rickets or hypophosphatemic rickets, and incontinentia pigmenti. Okay, as I told you, X-linked recessive, most of the disorders जो तुम कहीं और classify नहीं कर सकते, you can just make a diagnosis of X-linked recessive usually. ठीक है? So that is one of the common ones, X-linked recessive. ठीक है ना? Autosomal dominant का I have given you a mnemonic. He has a very dominant father. Okay, he has a very dominant father. That was our mnemonic. Dominant से पूरे एक ये था. So dominant से N here goes for usually neurofibromatosis. So as I told you, याद रखना, I told you X-linked recessive are some exceptions and autosomal dominant are some exceptions. So usually they like to ask you questions on either X-linked recessive or autosomal dominant. So here neurofibromatosis is usually an autosomal dominant pattern of inheritance. ठीक है, याद रखना. No issues with this. So I hope this was easier for all of you now. I have told all other autosomal dominant disorders also. जिनपे पहले question पूछा गया था. I told you osteogenesis imperfecta was a previous question which has been asked. Tuberous sclerosis which was a question which has been asked prior. Okay. So all of these questions, or von Willebrand disease was a question which has been asked. Okay, no issues with this, anybody? Whereas in NEET PG this time there was a question on color blindness. There was a question on color blindness prior, that was X-linked recessive. This time in NEET PG there was a question on cystic fibrosis, which was autosomal recessive. Okay. Moving further, question number 110. On uterine contractions, there is cervical dilatation and delivery. Which of the following shows similar mechanism? So on uterine contraction, when there is prostaglandin release, so क्या होता है? Whenever there is rupture of membrane, सबसे पहले there would be rupture of membrane that will release prostaglandins. Once prostaglandins are released, that will induce uterine contraction. Once uterine contraction gets so intense, that will they lead to cervical effacement or cervical dilatation, and then there would be usually delivery of the child. So which of the following shows similar mechanism? That is contraction of smooth muscles. Usually, option A says water retention by ADH. No, water retention by ADH is usually done by reabsorption from the collecting tubules, right? Via the aquaporin or V2 receptors. Okay? So this is not by contraction of the smooth muscles. So no similar mechanism is seen. FSH secretion by anterior pituitary. No, this is a secretory phenomena. Okay, so here the gland will release the secretions of gonadotropins or FSH into the blood directly. That is what is your FSH secretion by anterior pituitary. Okay, so here it is option C, milk ejection by oxytocin. ये भी बहुत बार discuss कर लिया था. Prolactin synthesizes milk, oxytocin ejects milk. So milk ejection by oxytocin is usually due to smooth muscle contraction. As we discussed, oxytocin is secreted by the posterior pituitary or the neurohypophysis, and it will lead to contraction of the smooth muscles, and therefore it will lead to labor during the delivery. Along with that, it will also cause milk ejection during lactation period or breastfeeding period, right? And oxytocin during the last time also there was a question, a patient during lactation is experiencing breast pain. So it is due to which hormone? So it is due to oxytocin because it causes contraction of the smooth muscles. Okay? Moving further to question 111. Now the question says insulin dependent GLUT4 transport is done by which of the following method? So I hope this was easy. We have discussed about all the GLUT transporters in biochemistry chanting, right? So we have discussed about GLUT1, 2, 3, 4. So we know GLUT1 is usually present. Okay, GLUT1 is usually present in brain, placenta, kidney along with RBCs. GLUT3 is only present in brain, placenta, kidney, no RBCs. GLUT2, as I told you, GLUT2 is usually responsible for insulin secretion. वो insulin को secrete कराता है. So it is usually present in lip, that is liver, intestine, and pancreas. Whereas GLUT4, as I discussed, it is usually a insulin-dependent glucose transporter. मतलब it needs insulin for its transport of glucose. ठीक है ना? So insulin is the stimulus for this GLUT4, right? So it is an insulin-dependent glucose transporter, that is GLUT4, and it is usually present. GLUT4 is usually present in adipose tissue, the skeletal muscle, or the cardiac muscle. So all of this we have discussed in great details, right? So insulin-dependent glucose transporter is GLUT4, present in adipose, skeletal, and cardiac muscles usually. And usually it is all types of GLUT are usually an example of option D, facilitated diffusion. They are examples of facilitated diffusion. ठीक है ना? Simple diffusion when the substance is transferred from one, like the substance is transported from high gradient to a low gradient. That is what is a simple diffusion. Facilitated diffusion when a substance is transported from a high gradient to a low gradient with the help of a transporter. That is what is a facilitated diffusion. Then active transporter are usually against the gradient. मतलब from low gradient you need to transport to the high gradient. अगर ऐसा कुछ transport करना है, then you require ATP for the transport, and when you use ATP, then it is what is called as the active transport. It can be a primary active transport or a secondary active transport. So primary active transport we know when the transporter itself or directly uses ATP. That is what is your sodium potassium ATP is pumped. That is what is your sodium potassium ATP is pumped. Okay, so it usually directly uses ATP in the patient. Therefore, it is an example of primary active transport. Whereas secondary active transport, it is due to SGLT. Okay, SGLT, as we know, it is a sodium dependent glucose transporter. So sodium dependent glucose transporter is usually a secondary active transport, guys. Over here, it does not directly use ATP, but it uses sodium. इतना हमें पता है. Sodium potassium ATPase pump से क्या होता है? Sodium is thrown out of the cell and potassium is taken inside the cell, okay? And it uses ATP. So it is a primary active transport. And when you have sodium outside the cell, then it is used by SGLT, that is sodium dependent glucose transporter, for transport of glucose. Therefore, it does not directly use ATP, but it uses sodium, which is dependent on a primary active transport. So therefore, SGLT is a secondary active transport. No issues with that, anybody? SGLT 1, 2, both of them we have discussed. Question number 112. Artificial bruise can be differentiated from a true bruise by which of the following? This also we have discussed in forensic medicine. Dr. Vikas would have discussed it. So artificial bruise and true bruise. Usually these are two important things that you need to differentiate. Artificial bruise is also called as a fabricated bruise or a false bruise. Matlab jo bruise या contusion. Bruise is what? Bruise is contusion. Okay. So bruise matlab it is due to rupture of the venules. So जब venules rupture हो जाता है skin में तो reddish discoloration occurs. That is what is a bruise or contusion. So it can be either a true bruise or a pseudo bruise, also known as artificial or a fabricated bruise. So fabricated bruise कैसे आता है? Fabricated bruise is usually due to the acidic juices. Okay. Fabricated bruise is usually due to the acidic juices, and the acidic juices are usually either semicarpus anacardium. Okay, it is acidic juice of semicarpus anacardium, also known as your marking nut. Okay, also known as your marking nut or bilava seeds. Whereas the another one is your rui, that is also known as calotropis. Right, so calotropis juice or semicarpus anacardium juice can lead to artificial bruise. Okay. So this artificial bruise, how you can differentiate it from a true bruise? Of the best option would be option A, that is presence of vesicles. Presence of vesicles characterizes an artificial or a fabricated bruise, whereas vesicles are not present in a true bruise. Okay, please remember this. Color change noted with time. Color change is usually noted with time in cases of a true bruise. Color change with time is usually seen in a true bruise. जब true bruise होता है ना, usually there would be color changes which are seen. पहले red होगा, then brick red होगा, then it will turn blue, okay, then it will turn black, all of this. So usually a true bruise will show color changes with time, not an artificial one. Diffuse irregular margins are also a feature of true bruise, whereas no inflammation is also a feature of true bruise. Inflammation अगर present है, then that is a feature of artificial or fabricated juice. Inflammation क्यों होगा या vesicles क्यों होंगे? Because it is due to the acidic juice which is there. ठीक है? Question number 113. Grievous hurt is said if a person is in severe body pain or unable to perform the routine activities for a minimum of how many days? So grievous hurt and hurt, दोनों की definition easy है. Hurt is usually a normal injury to a person, ठीक है ना, जिससे उसका ज्यादा नुकसान नहीं है. But grievous hurt is when the person is having a severe body pain or is admitted in a hospital or he is not able to perform his routine activities for a minimum duration of option C, 20 days. That is the closest one. Okay. So 20 days or sometimes they can mention you 3 weeks. That is the best answer to be marked. Okay. 20 days में अगर वो hospital में है or the patient is suffering from severe body pain or not able to perform his routine activity, or there is a loss of anatomical part or loss of some physiological function of body. Okay? That is what is a grievous hurt. As we know, definition of hurt is usually given in an IPC section 319, whereas definition of grievous hurt is given under IPC section 320. Okay? So I hope this was easy. Moving further now. Question number 114. A young female presents with 3 by 3 centimeter mass in the left breast. On examination, the mass was freely mobile. So freely mobile breast mass is usually known as the breast mouse. ये हमने discuss कर लिया है surgery में multiple times. Just sir also discussed in a sessions. I have discussed it in my chanting session. So a 3 by 3 centimeter mass in a younger female, 15 to 30 years of age group. Usually 15 to 30 years of age group, young female presenting to you with a breast mass and it is freely mobile. That is known as the breast mouse. What is the most likely diagnosis? So usually this mass on mammography will show popcorn calcification. This is nothing else than option C, fibroadenoma breast, which is a benign tumor of breast. Okay? No issues with this. Cystosarcoma fibroids, it would not be a mobile tumor and it would be a huge or a giant tumor. Cystosarcoma fibroids or a fibroid tumor, it would be a giant tumor along with skin's color changes or pressure necrosis which is seen. Okay? It would not be a small mass. Take a breast abscess, as I told you, it would be a fluctuant mass on palpation. It would not be a firm mass. And please remember, there would be other signs of inflammation as well at the site. Okay? Breast cancer usually is seen in elderly females around 40 years of age group. Okay? Then the chance increases. And in breast cancer, as we know, there is a rapidly growing mass and it is usually adherent to the surface, not freely mobile one. Okay? So this is a classical case. Question number 115. A female patient after a laparoscopic cholecystectomy presents with a cystic duct stump leak. What shall be the immediate management? So I hope all of you are quite aware. when we remove the gallbladder, so here, while we remove the gallbladder, two clips are applied. One at the cystic duct and the other is applied at the neck of the gallbladder. Okay? So usually in between this, we cut the gallbladder and then we remove it by laparoscopic method. Okay? So this is the method of laparoscopic cholecystectomy. But what happens sometimes? So please remember, this clip was applied at the cystic duct. Okay? But what happens at the cystic duct stump, these clip actually maybe due to some other reason, there would be increased pressure in the common bile duct, and that can lead to dislodgement of the clip. One of the common reasons is while you were removing the gallbladder, some gallbladder stone actually slipped into the common bile duct, that caused obstruction, or maybe there was a gallbladder cancer that was, bile duct cancer that was causing obstruction, and therefore there was an increased pressure in the common bile duct. As there was increased pressure in the common bile duct, this clip dislodged. Okay, ये clip निकल गई, and due to that there was a cystic duct stump leak. यहाँ से leakage होता रहा bile का. So this is what is the case. What is the immediate management? So if here you, option A says Roexenva hepaticojejunostomy. No, hepaticojejunostomy, as we know guys, it is usually done in cases of biliary atresia. Type 1 biliary atresia जो था हमने we discussed over there, we do hepaticojejunostomy. In type 2 and 3 we do Kasai operation, right? Over there we do hepaticojejunostomy. Or if there is a stricture of the bile duct which cannot be repaired, okay, there we can do hepaticojejunostomy. Option B says antibiotics with conservative management. No, conservative management agar tum karte rahe, the bile leak can increase and that can even cause inflammation in the peritoneum and can cause peritonitis in the patient. Exploratory laparotomy ki zarurat hai nahi as such as a, okay. So here you will prefer going by ERCP and do a stenting in this patient. Okay, no issues with this, anybody? Sorry. So please remember guys, usually here you will go by ERCP and do a stenting or apply a clip again. Okay, that would be the best answer over here. Next, question number 116. Which among the following is type 3 choledochal cyst according to the Tudani's classification? Tudani's classification of choledochal cyst we have discussed already. This was the image I discussed with all of you guys. So, sorry. So this was the image I discussed with all of you. So the first one that you can see, type 1 usually, so you can see type 1 is usually a extrahepatic cyst, only a single extrahepatic cyst that you can see over here. Type 2 is usually a extrahepatic diverticulum. Type 2 is usually a extrahepatic diverticulum. Type 3 is usually a choledococele. When usually there is type 3 is usually a choledococele when there is a choledochal cyst usually in the bile duct. That is what is called as choledococele, or in the duodenum. That is what is a choledococele. Okay, type 4A is extra as well as intrahepatic cyst. Extra as well as a intrahepatic cyst. Type 4B is usually a multiple extrahepatic cysts are seen. And type 5, as we know, multiple intrahepatic cysts within the liver are seen. That is also known as Caroli's disease. So here, most of you have said me that, sir, it was a choledococele. Okay, it was a choledococele, as you can see over here. At the level of the duodenum or at the level of the common bile duct, there was a choledochal cyst. So this is what is known as a choledococele. Okay? And it is a type 3 choledochal cyst. Okay, so please remember, type 3 choledochal cyst is nothing but a choledococele, which is a choledochal cyst at the level of CBD or at the level of duodenum, and that is what is seen in the option B over here. No issues with this, anybody? Moving further. Question number 117. Which among the following is the best investigation for the diagnosis of gastroesophageal reflux disease? Good. हमने discuss करा है बहुत बार. I have discussed it in surgery, medicine, all of that. And all of you were able to mark it right. I'm glad. So we have discussed that usually the first line investigation for GERD is definitely upper GI endoscopy. But the best investigation or the gold standard investigation for diagnosis of gastroesophageal reflux disease is nothing else than option B, 24-hour ambulatory pH monitoring. Okay, we'll monitor the pH of the esophagus for 24 hours. Okay, and normal pH of esophagus is 5 to 7. But if the pH of esophagus drops to less than 4 for 4 times in a day, okay, the pH of the esophagus drops to less than 4 for 4 times in a day, then that is what is called, then that is what makes the diagnosis of the gastroesophageal reflux disease, and the score is known as Johnson-Demeester scoring. Okay? I hope this was easy. Manometry is used for diagnosis of Zenker's diverticulum, or it can be even used for Zenker's diverticulum. में rarely use करते हैं. Mostly for Zenker's, we usually use a barium swallow. Okay, for Zenker's, we use the investigation of choices as Zenker's one. Esophageal manometry is used for achalasia, cardia, or diffuse esophageal spasm. Okay, no issues with that. Question number 118, guys. Now, a 35-year-old male diagnosed with gastric outlet obstruction. So this is your stomach, for example, and this is your pylorus. So maybe there was some gastric outlet obstruction. There can be multiple causes for this. It can be a congenital hypertrophic pyloric stenosis. It can be a peptic ulcer usually, or the most common cause worldwide is usually the this one, gastric cancer. But in India, gastric cancer is not very much common, and it is common usually after 50 years of age group. Agar India mein hai bhi, so it is common usually after 50 years of age group. Here the patient's age is 35. So here the more likely cause would have been peptic ulcer disease, which is more common in the first part of the duodenum, and therefore that might be the cause behind this gastric outlet obstruction. Now the patient presents to ER with multiple episodes of vomiting. So if the patient is having chronic vomiting or multiple episodes of vomiting, what would be thrown out? Definitely there would be there would be acid which is thrown out of the body, right? So the acid from the stomach, that is hydrochloric acid or HCl, is thrown out of the body. Or agar acid ja raha hai body ke bahar, the patient will suffer from metabolic alkalosis, right? The patient will suffer from metabolic alkalosis. So which among the following is the preferred fluid for this patient, they asked. So मैं एक फंडा बता दूं, CHPS and gastric outlet obstruction or chronic vomiting will have the same funda. Or in all these cases, what is happening? The patient is having chronic vomiting. Due to vomitus, what happens? The gastric HCl is thrown out of the body. When HCl or H plus ions are thrown out of the body, the patient suffers from metabolic alkalosis, right? Because acid is thrown out. So as the patient suffers from metabolic alkalosis, what happens now? Usually, to overcome this alkalosis, body tries to throw out bicarbonates out of the body. So in urine, usually there would be excretion of bicarbonates. But हमने देखा है कि bicarbonates हमेशा अकेले नहीं जाते. They always take sodium with them because there is a symporter, right? We have discussed all of this, guys, in every other session. ये सबको पता है. So bicarbonates along with sodium are thrown out. But sodium जैसे thrown out होंगे, there would be hyponatremia in the patient, right? So these are the two important things. There is metabolic alkalosis. So, and along with hyponatremia. So hyponatremic metabolic alkalosis is seen in the patient, and therefore you also need to give sodium in the patient. Ringer lactate, please remember, ringer lactate usually will have normal amounts of sodium, not high amounts of sodium. Sodium in a higher amount, usually normal saline, that is 0.9% NaCl. Okay? 0.9% NaCl mein sodium is usually seen in higher amounts as compared to ringer lactate. Okay? As compared to ringer lactate, it is higher in normal saline. So the better fluid of choice would be option A, normal saline in this condition. Okay? Moving further, question number 119. A 34-year-old female with history of alcohol intake was taking non-steroidal anti-inflammatory drugs, that is NSAIDs, for pain abdomen. She develops severe diffuse pain in the abdomen. X-ray performed is given below. What is the diagnosis? So I hope this was a question most of you have given a recall. 34-year-old female with history of alcohol intake. So जब वो alcohol ले रही थी, she was taking NSAIDs for pain abdomen. Okay. So for after alcohol intake, definitely she might have had gastritis in the patient. Okay. And for that, she might be taking NSAIDs for pain abdomen. But due to NSAIDs, as we know, NSAIDs are the most common drugs responsible for peptic ulcer disease, and they can cause acute onset peptic ulcer, okay, or erosive type of gastritis usually in the patient. And now she develops a severe diffuse pain in the abdomen. For that, she comes into the emergency, and X-ray was performed. The X-ray erect posture X-ray was performed, and here you can see there is some gas under the diaphragm, blackening under the diaphragm. This we have discussed already. This gas under the diaphragm is what is known as the cupola sign or the Moustache sign. Okay, cupola sign or the Moustache sign, and it is suggestive of it is a feature suggestive of pneumoperitoneum. It is a feature which is suggestive of pneumoperitoneum. No issues with this. So अगर pneumoperitoneum है, there is gas under the diaphragm. That means there is some perforation of the bowel or perforation of a hollow viscus, जिसकी वजह से क्या हुआ, air escaped out from the bowel and it is going under the diaphragm. Okay, so here the diagnosis, the patient might have developed peptic ulcer disease due to intake of NSAIDs or due to alcohol intake, and due to the ulcer there was an erosive type of ulcer and that has perforated finally, and due to peptic ulcer perforation, the patient would have this gas under diaphragm or pneumoperitoneum which has developed. So this is option C, bowel perforation. Okay, perforated liver abscess, if it would have, याद रखना, liver abscess में there would be features of peritonitis. There would be high grade fever, diffuse abdominal pain, tenderness, all of these features. ठीक है? And the patient would not give usually history of alcohol intake or NSAIDs intake. Rather, the patient will give you history of right upper quadrant pain. Okay, ruptured ectopic, definitely that will present with hemoperitoneum, where there would be Cullen's sign, discoloration around umbilicus or great earnest sign in the flanks when there is reddish discoloration. Okay, that is what is a ruptured ectopic, and the patient will have lower abdominal pain. ठीक है ना. Acute pancreatitis में also there would be features same as ruptured ectopic. There would be hemoperitoneum, colons of great Turner sign, and there would be pain which is radiating to the back. That is what is pancreatitis. And on X-ray there would be a colon cutoff sign, not a gas under diaphragm. ठीक है. Question number 120 now. A 22-year-old male had acute appendicitis and now presents to emergency with abdominal tenderness. Maybe the acute appendicitis has exacerbated. Now the patient cannot bear the pain anymore. Which of the following incision is appropriate for his condition? So now we need to perform an emergency appendicectomy. So now which of the following is best? Nowadays, most of us usually for routine appendicectomy, we can do a laparoscopic one. But open appendicectomy is usually done in much of the clinical practice, okay, because the patient is having abdominal tenderness and there is a high risk of perforation or rupture also. So if there is high risk of perforation or rupture of appendix, we might need to do a peritoneal lavage. So for that, we better do a open appendicectomy in emergency cases. Yaad rakhna. So here you can see there are various types of incision which are given. We have discussed about the incisions even. Sub incisions discuss kare the maine. So this 4 number that you have, it is usually at the McBurney's point. McBurney's point, as we discussed, it is 2/3 from the umbilicus, whereas 1/3 from the anterior superior iliac spine, right? So this is what is the McBurney's point, and it is a topographical landmark for your appendix. So this McBurney's point pe agar koi incision hota hai, that is what is called as the McBurney's incision. Whereas over here, if I give an incision, okay, a transverse incision, it is known as the Lanz incision. Definitely, we prefer giving a Lanz incision because it gives a better view. Both of these are muscle cutting or both of these are muscle splitting incisions. Both of these are muscle splitting incision. And one more, as I told you, one more muscle cutting incision was over here. This was known as the Rutherford-Morrison incision. That was a muscle cutting incision. So therefore, we avoid Rutherford-Morrison incision. Rather, we prefer either McBurney's or Lanz incision. Lanz incision, बहुत लोगों ने बोला कि it was not given in the option. McBurney's was given. So McBurney's is option D. That is 4 number incision. That is McBurney's incision. It is usually preferred for appendicectomy in the patient. Okay, no issues with that. Just a minute, guys. Okay. So here you can see the other incisions. Usually the first one that you can see, the first one, that is usually a Kocher's incision. And Kocher's incision is usually done for cholecystectomy. Laparoscopic cholecystectomy ke liye, ya baki open cholecystectomy ke liye, we can do this. The 2 number one is the paramedian incision. Third one is the median incision. And paramedian or median incisions are usually used for exploratory laparotomy. When there is a perforated appendix, we need to give up median or a paramedian incision, क्योंकि वहाँ पे हमें we need to explore all of the peritoneum properly and wash it off. Okay, so that is the reason. Question number 121. What is the diagnosis based on the given image in a newborn? So I hope this was easy for all AFMG students. We have discussed this in surgery chanting as well. The same image as I discussed, this was an invertogram. What is this investigation? This is a invertogram. Okay, most of you have seen it for the first time, as I told you. So this was an invertogram when a child usually 6 to 12 hours after birth is held in a reverse position. That means the legs are held up, okay, and we wait for at least 3 minutes, and then we take an X-ray. And while we take an X-ray, we place a coin at the level of the anal dimpling. Okay, so it is usually done. This invertogram is usually a X-ray in the invert fashion. It is done to assess for any anorectal malformation. कि बच्चे में कोई anorectal malformations तो नहीं है, anal canal malformation or a rectum malformation. So for that we do this invertogram. Here we place, if the patient is having imperforate anus, as I discussed you, we will place the coin at the level of the expected anal opening. Okay, at the level of the expected anal opening, and then you will calculate this distance. Then you will calculate this distance between the gas bubble and the coin. Okay, so if this distance is less than 2 centimeter, you will call it as a low anorectal malformation. If the distance is more than 2 centimeter, you will call it a high anorectal malformation, and depending on that, you will decide your treatment strategy. Okay, no issues with this. So this was discussed. So gas bubble से लेके coin तक का distance measure करते हैं. Depending on that, we decide whether it is a high or low anorectal malformation. Here they have just asked you, based on the given image, what is your diagnosis? So the given image was invertogram. Here they were looking for option B, imperforate anus. Okay, so they were trying to look for the repair. Hirschsprung disease, please remember here there would be dilated colon, and usually they will give you an image of barium enema. Okay, na? And there would be a proximally dilated loop of intestine and distally collapsed loop of intestine which basically. Okay? Moving further, question number 122. A female patient while washing clothes in cold water exhibit color changes of her hands. So on cold exposure, when a female is having color changes in her fingertips or on hand, when it changes from white to blue to red, this is nothing but definitely your Raynaud's phenomena. This is nothing but your Raynaud's phenomena. If it is not having any cause, idiopathic hai, then it is a primary Raynaud's phenomena or Raynaud's disease. Whereas if it is associated with some secondary, if it is secondary to any connective tissue disorder, then it is called as a secondary Raynaud's phenomena. सब कुछ discuss कर चुका हूँ multiple times Raynaud's. So which of the following drug is best suited for this patient? As I told you, Raynaud's phenomena होता क्यों है ये discuss किया था हमने details में, because there is spasm of the arterioles as well as the venules. So दोनों पहले spasm में चली जाएंगी, arterioles as well as venules. So there would be complete cut off of blood supply leading to white color. Then क्या होगा? Usually the venules will dilate, but the arterioles are still constricted. As the venules will dilate, the deoxygenated blood is accumulated, and that would lead to a blue color. And finally, when the arterioles will dilate, then there would be a blood supply which is restored, and then there would be redness. Okay, so white, blue, and red. WBR was the color change sequence. So there is vasospasm which is seen. So vasospasm में तो क्या दोगे? Vasodilators दोगे, and the vasodilators which are usually preferred, it is option C, calcium channel blockers. Okay, so calcium channel blockers are usually preferred for Raynaud's phenomenon in the patient. Moving further, question number 123. A chronic thin male smoker suddenly collapsed and was brought to the emergency. Chest X-ray image is given below. What is the next step of management? So I hope this was pretty easy. Maybe some people are saying the X-ray was not easier to diagnose. There were 2 or 3 questions about pneumothorax. I hope so. So here they are saying the patient was a chronic thin male smoker. So as I've always told you, thin male smoker, usually you need to think in terms of emphysema. When there would be hyperinflation of the lungs, matlab increased blackening of the lungs is seen. Here you can see there is hyperinflation of lungs along with flattening of diaphragm. Okay, but on one side, along with flattening of diaphragm, you can also see there is a dip, and this dip, as we know, it is known as the deep sulcus sign. This is known as the deep sulcus sign. Along with that, to differentiate the right and the left side, you can see easily both sides there is hyperinflation. दोनों side में hyperinflation because the patient is having emphysema, right? COPD का patient है. But along with that, what difference you can see over here? So here you can see on the right side, the patient is having the bronchovascular markings. Okay, the patient is having bronchovascular markings. So vessels वगैरह की markings दिख रही है. But on right side, but on the left side rather, no bronchovascular markings are seen. So if there is absent bronchovascular markings along with tracheal shift to the opposite side, right, or contralateral shift of the trachea along with deep sulcus sign, then this is a classical picture, guys, of pneumothorax. And if a patient develops pneumothorax, usually after emphysema, so emphysematous patient develops pneumothorax, then this is what is called as a spontaneous pneumothorax. What happens in emphysema? In emphysema, there is air trapping, and that leads to formation of the bleps of bullae in the lungs. When these bleps of bullae will rupture, that can cause spontaneous pneumothorax due to escape of air into the pleural cavity, and that leads to this features on the X-ray: hyperinflation, flattening of diaphragm, deep sulcus sign, along with absent bronchovascular markings and contralateral tracheal shift. Diagnosis of spontaneous pneumothorax and the treatment. The next step of management, as we discussed, for emergency, the management could be needle thoracocentesis. Here they have given option A, wide bore needle insertion. As we discussed, if it is spontaneous pneumothorax, it should be done in the it is usually done in the second intercostal space, mid-clavicular line. If it is a patient of trauma and after that the patient presents to you, then it would be a tension pneumothorax. Over there, definitely, I will go by the ATLS protocol, the updated guidelines, and there I'll insert the wide bore needle in the fifth intercostal space, mid-axillary line. Okay? And if they ask you for definitive management, definitely definitive management is ICD insertion or chest tube insertion. Intercostal drainage tube is inserted, fifth intercostal space, mid-axillary line. Okay? No issues with that. So this was easy. Question number 124. What does the following X-ray depicts? So here you can see, we have discussed it multiple times in all the image-based sessions, whereas in medicine also I discussed. Here on right side, you can see the patient is having, on right side, the patient is having some fluid accumulation on the right lung, in the right lung, okay? So this fluid accumulation is usually seen in the pleural cavity, okay? And that leads to this curve which is seen. This curve is what is known as the Ellis curve. ये मैंने discuss किया था. Okay, this is known as your Ellis curve, also known as your Witt sign, also known as your meniscus sign or crescent sign. Okay, half moon shaped है ना? So meniscus or crescent sign, or classically called as your Ellis curve. Okay, so this is usually a feature along with blunting of the costophrenic and the cardiophrenic angle. So both the angles, costophrenic as well as cardiophrenic angle, both of these angles are blunted. So this is the classical picture of accumulation of fluid inside the pleural cavity, that is called as hydrothorax or pleural effusion. So this is a classical picture of option C, pleural effusion. Last two questions now. Last one question. Which graft will be used in coronary artery bypass grafting with long-term patency? So as we know, usually if a patient is having a triple vessel disease, that means blockages in 3 coronary arteries, we prefer doing a CABG, coronary artery bypass grafting. And in this, we need to use some graft, okay? And the graft usually for coronary arteries would be best if it is an arterial graft. Okay? Great saphenous vein is a good graft, but it is not an arterial graft, so not the best graft overall. Okay? Radial artery is a graft which can be used, but not the most commonly used or the best graft. Okay, so the best graft for CABG with long-term patency is definitely option A, that is internal mammary artery, either a left internal mammary artery LIMA or a right internal mammary artery RIMA. So LIMA or RIMA, as I told you, these are the best coronary grafts, best graft to be used for CABG procedures. ये हमने discuss कर चुके हैं. Okay, I have discussed this with all of you. Okay, no issues with this. So internal mammary artery is the best graft to be used. Why? I have given you the reason as well, because these are the arteries with least chances of atherosclerosis. Okay, least chances of atherosclerosis are usually seen with LIMA or RIMA, and therefore these are the best grafts to be used for long-term patency in CABG procedure. Okay, with this, I end the session for today. Thank you so much. If I get more number of recalls, definitely I'll come with the next session as well. Thank you so much. Till then, goodbye, good luck, and I hope all of you have done really well in the examination. Don't think much. Enjoy your days now till the result. Okay, till then I'll meet you in the next session. Thank you so much, and